Ma'am,
Hi.
we are in live.
Yeah, stay live. Okay. Very good evening to one and all of you for another high educational initiative of arts. And I'm sure with the kind of galaxy of stars which I hear, we are going to have a great 2 hours ahead. So this time it's the Road to Recovery, a case-based clinical approach in ocular trauma. And I'm sure the types of topics which is lined out is going to be of great practical relevance to who all are watching it. So we are lucky to have on our expert panel Dr. Sonam Nizar, who's a consultant orbit oculoplasty, aesthetic and reconstructive services from Shankar Nethralaya, Chennai. We are truly lucky to have joining us soon Dr. Raguraj Hegde, who is a consultant of orbit ophthalmic plastic surgery and ophthalmic oncology services from the Department of Ophthalmology, Manipal Group of Hospitals, Bangalore. We have with us, we are lucky to have with us Dr. Roshmi Gupta, who is again orbit oculoplasty and ocular oncology surgeon from Trustwell Hospitals, Bangalore. We are lucky to have with us Dr. Vijay Natarajan, who will be joining us soon, who is again the chief of the orbit oculoplasty and ocular oncology services from the Arvind Eye Care Services based at Coimbatore. Moderating with me, or rather leading the show, would be Dr. Vidya, who's our senior consultant oculoplasty from the Eye Foundation group of hospitals. So I think without wasting time, we'll go on to our first speaker, Dr. Sonam Nizar, who's going to talk on something very basic and relevant to us in ocular trauma, and that is ocular adnexal injuries, approaches and outcomes. So on to you, Doctor.
Thank you. Thank you so much, Dr. Chitra and Dr. Vidya, for this opportunity. And it's great to see everybody here. I'll just quickly share my screen. So, yes, I hope the screen is visible. Right. So ocular trauma is all about dealing with the blows, and we as oculoplastic surgeons mainly deal with eyelids and the adnexa. But it is very important to also remember that we are ophthalmologists first. So I'll just be, the outline is just going to be about the anatomical considerations, the modes of injury, assessment, classification, and then the management and special considerations. So it is very important to understand as a trauma specialist, the anatomy, because when you get a case, you're not going to get everything in its piece. It's going to all be a puzzle that you actually have to put it together. So just the brief of it is that you need to know where your medial canthus and lateral canthus lie in position with each other. We all know that the lateral canthus lies about 1 to 2 millimeters higher up compared to the medial canthus. We know the lid has 3 lamellas, that is the anterior, middle, and posterior. Anterior lamella consists of the skin and orbicularis. The middle consists of your orbital septum and LPS. And the posterior lamella consists of your conjunctiva and your tarsal blade. Once you know all this, it becomes very easy when you actually get a case to plan the management. Also, you have to understand that if there is a trauma medially, there's very important structure that is a lacrimal drainage system, and that is the canaliculus puncta, along with the NLD and the lacrimal sac also in that area. If you have an injury which is right in the center, you know your cornea and your globe is right there. So it is always important to also look for any associated globe injuries. Now, when you actually find a patient who comes to you, it's very important to understand how the injury has actually occurred, when the injury has happened, whether it is with a projectile object or it is a blunt trauma. When the patient comes to us, also it is important for us to know that we are doctors first. So ABC, that is airway, breathing, and circulation. These are the most important things that first we have to look for, and then go on to the ophthal part of it. It is also important to look for double evert, always the lid, look for any foreign body lying anywhere else, because many a times patients just comes to us with foreign body sensation and some vague history, and when you forget to evert and you see just a small corneal aberration, and you might actually see a foreign body lying in there. So now coming on to the orbital and adnexal injuries in per se. So there is a very beautiful classification for the eyelid injuries and eyelid tears that has been proposed by Devi Prasad Mohapatra et al. And they are very beautifully actually just divided it into zone 1, zone 2, zone 3, and zone 4. So zone 1 is where you just have the upper lid that is involved. And all the zones just have either superficial injury, that's an abrasion, or you have partial thickness injury. Partial thickness injury can be associated with or without tissue loss. Third is the full thickness injury. Now, as as oculoplastic surgeons, we know that if the injury or full thickness wound defect is less than 1/4, you can directly close it. If it is 1/4 to half, then you need to do some further procedures to assess anterior and posterior lamellar loss and then plan the further management. And third is where there is almost near total or more than half of tissue loss, which is there in the upper eyelid. Very important to understand that it is your upper eyelid that is more dynamic. Your lower eyelid is more static. So upper eyelid reconstruction is extremely important. Second is the low. Similarly, with the lower also is divided into superficial, partial thickness with or without tissue loss and full thickness. Medial canthus also similarly and lateral canthus. So based on the area, you can actually divide into zone 1, 2, 3, and 4. And any combination is involving any further zone. So this is important also when you're referring a patient. We can actually look at it and understand where the injury was initially when you're referring a patient and if we have to do a secondary reconstruction also. So when a patient comes to us with injury, besides history, it's also important to understand whether they've taken any tetanus prophylaxis or not. Patient is systemically fit or not. And if it's an adult patient, we prefer to do it under local anesthesia. And by protocol, pediatric patients, we do surgery under general anesthesia. Also, there are some things that we must keep handy with us while repairing the eyelid and adnexal tears is you know that there is a canaliculus there. So it is important that you have a mini monoca or a silicone tube ready in case you have to cannulate the canaliculus, or a stent is readily available. You have other intubation, lacrimal intubation tubes also. Now, eyelid skin is extremely thin. So we cannot use like general surgeons 20 or 30 sutures. We need to use very fine sutures, which will be more aesthetic also in its outcomes. So we use 60 Ethelon, 60 Vicryl, 70 Vicryl, and 80 Vicryl. These are three things that you must have handy in your setup. Now let's go on to the case scenarios. As you can see here you see an upper lid full thickness tear, avulsion rather, involving the canaliculus. So you have to, and that is one. Here there is no tissue loss. You can see the opening of the canaliculus also here. Here you see a wedge-shaped injury. It's just a full thickness lid tear, upper and lower lid. Both the lids are involved here. Here you see that it is laterally avulsed. The eyelid is just avulsed, but it's intact completely. Here, as you can see in the lower picture, here there is an actual tissue loss along with a globe injury. So you can see here the patient's already undergone a PK and then we were called in for a eyelid repair. And last but not the least, we also need to assess the areas around the lid, that is the brow. You can see here also that there is a brow laceration. You can see the asymmetry in the brow and the defect which is there, which also needs to be repaired. So what are the principles before you go in and what are the do's and don'ts? Obviously, based on the history, you say if there's a dog bite injury or something, you have to give rabies vaccination. You have to wash the area completely. Besides that, copious irrigation, you have to rule out a foreign body. If it's organic, there's a high risk of infection. So all of those things we have to take into consideration. Next is obviously know your anatomy. So once you know the reconstruction as per your anatomical orientation, very important in a lid reconstruction is we never repair the septum. Because if you repair and suture the septum, it kind of compromises your eyelid excursion and worsens the lag of thalamus, which in turn worsens the exposure. Also, it is important how you close based on your choice, anterior to posterior or posterior to anterior. Always posterior to anterior is better because posterior lamella is actually covering and lining over the cornea. So if you close it well enough, you will not have any corneal abrasions, any corneal defects. Also, about the canaliculus, we have a separate session all over about it. So I'm not going to go much in details of that. As I already mentioned, we do not repair the septum and also do not shave the brow hair. So as you know, in surgery, we all are used to the area that you're going to suture, you shave off any extra hair. You do not shave the brow hair, otherwise we might lose the symmetry and also the orientation of the anterior lamella. Because anterior lamellar deficiency again can cause lag of thalamus, which can worsen corneal exposure. So how do we go about with it? So for superficial abrasions, there's not much that we need to do in the periocular area and the adnexa. You just do you can have probably collagen dressing and bactigras based on the depth and the type of injury that you have. A simple antibiotic ointment also suffices for just superficial abrasions. Also, mode of injury is important. If you have had an injury because of an alkali or an acid burn, then having a collagen dressing handy is makes more sense. If it is just a very superficial lid tear or a brow laceration that you're seeing, if it's superficial, then you can easily close it with either tissue glue or cyanoacrylate glue as well. And you can just close it and approximate it with steri strips as well. And let secondary healing do its job. Now, where we come into the picture is where you actually have a deeper laceration or a lid tear involving the lid margin. How do you suture that? Is $1 million question. So it's very simple. This is done by Mastari's.
Doctor, 1 minute more.
Yes, sure. So you can do it with the Mastari's technique. We first close the gray line, then we close the posterior lamella, and then we go on to the anterior lamella. And as you can see in the picture, it's closed basically with mattress sutures. And it is very important to note this point. You actually have to make it outing up and not straight. Otherwise, it will scar and it can cause a notch. I'm not going to go much into the video, but lateral canthal injuries, important thing is to maintain the angle, which is quite acute, and anchor it to the periosteum so that you have a good lateral canthus. Also, it is very important to understand the anatomy. As you see here, this is one layer, this is the fat which is prolapsing out, and not get confused with something else. So again, going back to the anatomy, some special considerations. If you have a patient with any Bulgahar injury, you can see here what has been missed here. This kind of worsened. It was just a simple laceration, turned out to be a mucormycosis. So you can have associated infections with a wound. Very important to send the samples for microbiology. Another thing, like I was mentioning about the lacrimal sac, if a patient comes to you with blunt trauma, you actually can have traumatic nasolacrimal duct obstruction. CT-DCG is a fantastic investigation of choice. And also, if you have a patient who comes to you post-trauma with conjunctival chemosis, edema, proptosis, do not forget you can have an underlying traumatic CCF also. So it is very important to be clinically alert. Thorough history taking, clinical assessment, very important. That lid tear is not an emergency. First, the patient has to be systemically stable. And yes, you should refer for complex tests to a proper oculoplastic surgeon. So thank you so much. I hope this sums up everything. Thank you.
No, it didn't sum up everything. It was a wonderful talk, and we could have heard you for another half an hour. It was so crisp and informative. So to start off with a basic question, what would be your treatment option if they come present late with some cicatricial changes in the eyelid? So how would you go about it?
There was one special consideration on that. So then it depends. We actually look whether it's the upper eyelid or it's a lower eyelid that is involved. We look for the amount of lag of thalamus and the anterior lamella. So as we know that the upper eyelid anterior lamella has to be about 20 millimeters. So if they have shortening of the anterior lamella, then we have to do a skin grafting, or depending upon the type of scar, we can do a Z-plasty also in that area. Lower lid also, if they come anywhere between 3 to 6 months, then you can actually try 5FU injections if there is no severe corneal exposure changes, and see if the scar itself can become softer and better. If they come after 6 months, then generally 5FUs or any scar management does not work, and we have to go in for any skin grafting or something like that.
Expert panel have anything to add on this? Dr. Vidya, could you take
Actually, thank you, Sonam, for a wonderful presentation. Just that I just want to ask you about the severity of the injury and its impact on the choice of your diagnostic imaging or test. Would you prefer to do anything like CT or MRI? I think that point has to be added to the discussion point. Yeah.
If it depends upon the history, if you have an if you have an injury with an organic foreign body or something, you want to rule out an organic foreign body, then always imaging should be done. If you see that there is a blunt trauma, then to rule out any orbital fractures. So MRI would normally do in case of any organic foreign body. CT scan, if you know that there is an iron particle lying there or something, then I would do CT scan. Also, in order to look for any extraocular muscle injury.
And what about the complex complex or combined ocular adnexal injury? Like sometimes we get not just a eyelid injury, it can be an eyelid injury and lacrimal system, or it can be a lacrimal and orbital fracture. So how would we approach, how does this approach to management differ in case of acute presentation versus long-term rehabilitation?
So acute, obviously, first we have whatever is open as a principle, whatever is open, it has to be closed. So first we'll do the lid tear repair. We do not ideally repair any nasolacrimal duct injuries in the same sitting if it's acute. Neither do we repair the orbital fractures in the same sitting. Though I have seen many maxillofacial surgeons
Yeah.
do OMFS repairs along with lid tear repairs in the same sitting, but we ideally would like to wait.
Okay. And in case of long-term rehabilitation, you would take as and when it comes, like a lacrimal first and an
Definitely.
orbital fracture.
We
Okay.
have to first intervene for any and rule out any focus of infection. So yes, first any traumatic nasolacrimal duct obstruction that has to be dealt with first. But we can definitely combine it with any lid procedures. Like for example, many a times if you have a medial canthal dystopia, and you can actually do a Z and through the same incision do an external DCR in the same sitting and address two things in the same time. You can actually address a telecanthus also in the same sitting with a
Yeah.
DCR.
So if you have a nasolacrimal, nasoethmoidal fracture and we suspect a lacrimal system involvement, would you be doing a diagnostic probing also at the same time, or would you prefer to wait, or how would
Yeah,
be?
can, but as you know, most of these injuries have secondary nasolacrimal duct obstructions because of scarring more. You can have lacrimal sac avulsions. So yes, we can do syringing in the same sitting. And if it's under general anesthesia, we can also visualize when we do with fluorescent stain syringing directly into the nose itself if they are under general anesthesia.
Right. Okay. Thank you. Thank you, Sonam.
And
Thank you.
anything
Inputs
else
from our expert panel members.
to add? And Vidya, you should be seen, Vidya.
Yes, yes, madam.
One question.
That's very important.
Yeah. Can we, Sonam, lovely talk. For the audience, would you want to outline a couple of sentences? What should be any ophthalmologist's approach to an animal bite injury?
Yes, yes, we need to make sure, first of all, first understand what animal was it, whether the animal is a pet or it's a wild, and whether the animal has been vaccinated or not. Irrespective of that, we have to do irrigation with immunoglobulin, and the wound has to be irrigated. And of course, they also have to take anti-rabies vaccination in case we are not able to trace the vaccination status of the animal. So that is there. Would you like to add anything else to that?
About the timing of the repair. So this I have not found really written out anywhere, but one of the major public health specialists, infective disease specialists, brought out this point that because it is in the head area, so don't repair the dog bite injury for 24 hours. Like clean, give them immunoglobulin, wait, then repair. Well, eyelid injuries, it doesn't matter if you wait for 24 hours. That's okay.
Okay, that's interesting.
Yeah. And
So-
ideally, we should be infiltrating the wound also with the immunoglobulins, no, madam?
Yeah, if it's not a vaccinated or we don't know the vaccination status, so it's 20 units per kg body weight, and then half of it around the wound itself, the other half another part of the body.
Yeah.
May I add a point?
Yeah, yeah.
Yeah, I think there is varied opinion on this waiting or not waiting. Most of the time, most of the articles that I have read is like in eyelids, you need not wait. You give a good wash, give a broad spectrum antibiotics, and start anti-rabies treatment, but you can repair early. But I don't know why this ID specialist has recommended that, but there is a variation in opinion. I would just like to point that out.
Yeah, even I would want to know if there is any specific reason why we should wait, because yes, they say that you should wait for 24 hours and irrigate many a times. I don't know.
The point is, the neural transmission of the viruses. And, head injury, head or face injury is considered more dangerous than a bite elsewhere. That's how.
Yeah, I completely agree with Dr. Preeti over here. I have seen cases which were, dealt with plastic surgeons, and they have waited for whole month till the completion of the vaccination, that is on the 28th day. And at that time, the whole lid has gone into, a cicatrix formation and scarring. So I always advocate and I tell my residents that do not wait. In the cases of eyelid, start vaccination, that is on the 0 dose on the day 1, and then do the repair after thorough debridement of the wound and give the serum also. But I think this should be the take-home message, that we should not wait in eyelid lacerations.
So amidst the confusions, we go on to our next speaker, Dr. Bhagwati Vadvekar, who is a professor at the Department of Ophthalmology, Oculoplasty, and is also a cataract surgeon from Sri Manakula Vinayakar Medical College Hospital, Pondicherry. And she's going to take on realigning canaliculate tips and tricks. On to you, doctor.
Good evening, one and all. Thank you very much, Dr. Chitra and Dr. Vidya, for this wonderful opportunity. Just so I'll be speaking on the canalicular lacerations, tips to the management. I'll be covering indications of the canalicular repair and when to repair and how to repair. The lacrimal drainage system injury forms around 16% of the all eyelid injuries, and mostly it involves the lower canaliculus, and it is more common, like any other trauma, it is more common in the children and the young adults. Hence, while repairing these injuries, we have to take into account not only the functional aspects, but also the cosmetic aspects. So we can divide it into direct injury and indirect injury depending upon the mechanism of the injury. Direct injury is caused by the sharp objects such as glass pieces or metal such as knife or spokes of bicycles, and the fencing and the cloth hangers. And blouse hook injury is more common in the breastfed infants. The indirect injury is caused by the blunt trauma away from the canaliculus. It can be caused by the fist, or it can be caused by fall from the contusion by a fall or the road traffic accidents. Sometimes the injury may not be very obvious, like this 10-year-old boy who had injury with the spokes of the bicycle, and this 11-year-old girl who had injury with the fencing while playing. And these injuries would have been easily missed if we would not have done probing. And they will heal with the scarring. And if you don't do probing, they will heal with the scarring and will lead to epiphora. Hence, in all the medial eyelid injury, we should suspect the canalicular tear. Indirect injury, usually it is away from the punctum lateral part of the lid, and this will stretch the lid to the point beyond the, it will lead to the avulsion of this medial part of the lid, which is weak. There is no tarsal plate in this area. In most of the indirect injuries, the cut is usually distal cut. The distal means it is towards the sac, whereas in the direct injury, the cut is towards the punctum, which is proximal cut. Now, this is important to know because the distal cut injuries, which is towards the sac, they are more difficult to manage in terms of the identification of the distal cut end. Medical management is like any other injury, that is ensure the tetanus vaccination, give the anti-rabies vaccine in case of the dog bite injuries, and give an antibiotic cover in case of the contaminated wounds. Now, all canalicular laceration needs to be repaired with the stenting to restore the eyelid anatomy, and so that the eyelid physiology and eyelid pump mechanism returns back to the normal. So all bicanalicular injuries, we are going to repair with the canalicular stent, and also the single lacerated canaliculus, there is a 10% risk of the epiphora. So repairing the canaliculus with the stenting not only reduces the risk of epiphora, but it also gives the good post-operative lid position and a good cosmetic appearance post-operatively. So timing of the intervention is no longer guided by the immediate intervention or historic recommendations of within 6 hours of the injury. We can repair anywhere between 48 to 72 hours. But as many of the cases are road traffic accidents, so they may have associated injuries also. So it may not be possible always to repair within 48 to 72 hours. But the successful outcome has been reported by many studies, even repairing 5 to 7 days after the injury. Now, these are the different options which we have, depending on case-to-case basis. I have no financial disclosures to make. So this is a mini monocast stent, which is available with the Oro Lab or FCI. And these are the bicanaliccular stents. The more popular one is Retlings and Crawfords, and this one is a pigtail probe. So traditionally, this pigtail probe and bicanalicular stenting was used to repair the canalicular lacerations, but these you have to pass through the normal canaliculars, and there is a risk of damaging the normal canaliculars, and these also requires much of the expertise. Now, the more popular ones today is mini monocast stent, which is simpler and non-invasive. There is no injury to the normal canaliculars. And in case of the bicanalicular injuries, you can even use the 2 monocanalicular stents. Now, we can give local anesthesia. The repair of the canaliculars with stenting can be done under local anesthesia. So first tip to management of the canalicular tear is to use the magnification. You can use magnification of microscope or the surgical loop. And second tip is to use very little amount of the local anesthetic. Third tip is to do a blunt exploration and keep your sharp tooth forceps for retracting the skin alone. And the first thing is to identify the cut ends, that is cut end. So this is a proximal cut end, which is towards the punctum. This is a distal cut end. The proximal cut end is easy to identify. You have to simply pass your probe, Bowman's probe, through the punctum, and you will see it exiting through the proximal cut end. But the distal cut end is difficult to identify. Immediately after the trauma, this cut end retracts into the orbit due to the contraction of the orbicularis muscle. And this identification of this distal cut end is difficult, and there are multiple techniques which is described in the literature, such as injecting air through this normal canaliculus or injecting the viscoelastic or the fluorescent stain dye through the normal canaliculus. But these techniques usually will be helpful only in case your cut is near the punctum or proximal cut. If your cut is very near the sac, you cannot visualize the fluorescent dye or viscoelastic coming out through the other cut, through the distal cut end. So I usually identify it clinically. That is, it is very important where you have to look in case of the indirect injuries or when distal cut end is towards the sac. So you have to look just below and behind the caruncle, and you can see the pearly white opening of the punctum, pearly white opening in the pink tissues of the orbicularis. So you can feel it is the walls of the canaliculus are very thick and elastic and rubbery. Once you feel it, you are never going to forget it. So once you identify the distal cut end of the canaliculus, you put a Bowman's probe through it, and when you have a hard stop, that means you are in right place. If you have a soft stop, then you have to do exploration again. So once you are sure that you are in right place, you have to put the stent. I usually use this mini monocast stent. So it has a body and a head. Body is around 40 millimeter in the length. This will go and rest into the canaliculus. And this one is a head which has a bulb. This is an ampulla. This will fix into the ampulla of the canaliculus, and this collarette will remain outside the punctum. So I have a small clip how to insert this stent. So you have to dilate the punctum first, and then you insert the tip into the punctum. You have to stretch the lid tight, and you have to put this perpendicular to the punctum and insert it bit by bit. And once you see through the proximal cut end, pull it out and then push the bulb into the punctum. You have already identified the distal cut end, so put it through the distal cut end. If you are in right place, you'll be able to pass the entire tube very easily. Now, once you have put it inside, you need to do suturing. So if your cut is towards the punctum, the suturing is very easy. It is like any other marginal lid tear suturing. But when cut is towards the sac, that is distal cut end is towards the sac, then you have to direct the vector of the medial canthal tendon toward the posterior lacrimal crest. So you have to pass a double-armed suture from the lateral part, lateral cut end, and then now when you are passing through the medial cut end, you have to swipe through the periosteum and come out through the skin of the medial, near the medial canthus, and tie it over the bolster. So this is a post-operatively how you will see the this stent outside. You can see the collarette. You can keep this tube for around 1.5 months to 2 months, and you can take it out under the magnification of slit lamp or the loop. You have to just pull with a tooth forceps this collarette and pull it out. So the take-home message is always suspect the canalicular tear in the medial eyelid injury. Whenever possible, do all canalicular repairs with intubation, and always use magnification. Thank you very much.
Thank you, Dr. Bhagwati. That again was a very nice talk. Vidya, could you take on the questions?
Yes, madam. Bhagwati, you have mentioned all the important points. The very important is the distal end, identifying the distal end which is close to the sac, like below and behind the caruncle, which is a very useful point because I usually find it difficult when it is a distal end. The identification and intubating it is very difficult as compared to the midway or close to the punctum, which is very easy, simpler. And when we use magnification, we can actually do it. And here again, I want other expert members also to comment any other tip to be followed when we do the distal end. So that is one question. The other thing is, what are the key aspects in the post-operative management, like how to prevent all those complications with stenosis, scarring, or infection? Anything that we need to be specifically looking for in the post-operative period, or anything different that we need to do in these type of cases?
Not.
Yeah.
Usually, I prescribe the even oral antibiotic for around 5 days and antibiotic drops for around 7 to 15 days. I think that's all. And we have to tell patient not to rub on that area so that the tube doesn't comes out.
And possibly we should be looking for corneal complications also if the collarette if it is not sticking on to the punctum. Yeah, that possibly has to be kept in mind when we follow it up. Okay. So any other comments or any other additional points that you want to give the other expert members?
I think
Just one more point regarding the that sign that is there, that the distal end of the sign. It's also called calamari sign.
Uh-huh.
yeah.
Yeah, so it's also called calamari sign. So that is one way to remember it. I mean, those who eat seafood would know that what is a calamari, but it's a good. I mean, it's a good thing to remember.
Okay.
You can blanch it with phenylephrine also, so that the
Correct.
surrounding orbic kind of gets blanched and you can identify it better.
Mhm.
I think Dr. Bhagwati has covered all the ways how to identify the posterior end, but in certain cases where it is just not possible to find, there is an instrument called the pigtail probe. But of course, we have to use it with great care, because you might actually perforate the one canaliculus which is actually uninjured.
Working.
So we only who are absolutely comfortable with using a pigtail probe can actually use a pigtail probe from the uninjured side and come out on the opposite side to identify the distal end in cases where all of these other techniques fail.
Okay. So in case
Thank you very
if the
much.
procedure
That's-
failed, if the procedure fails and we are not able to canalize the canaliculus, what are the options do we have in treating these patients?
You're asking me?
Yeah, any all of you like.
Yeah. So it depends on whether it's one canaliculus which is injured or both the canaliculi which are injured. And then again, it depends on the symptomatology. So if the patient is not very symptomatic, I would advise not to touch the patient. And in case the patient is symptomatic, then we can, and both the canaliculi are completely like scarred and we are not able to actually canalize it, then we are left with only either lacrimal gland options like Botox or needling of the lacrimal gland, or if we can do in certain cases, a conjunctival DCR with Jones tube is another good option.
So if it is involving the distal end, probably we can go ahead with external DCR with intubation also, right?
If both the canaliculi are completely damaged, and mostly in traumatic cases, these canaliculi are generally very scarred. So even if we actually go ahead with a trephination and put in a stent, once we remove the stent, they go back to having a scar in that area, because the mucosa has been replaced by fibrous tissue in these areas. So even if we want to go ahead and give it a trial, because of course that's more physiological procedure, we can try, but we have to tell the patient that the chances of success are very, very low.
Okay, got it.
Yeah.
So conjunctival DCR with Jones tube would be probably a better alternative and a more possible solution in these.
Yes.
Right.
I have one question, Vidya.
Yes,
Hello.
madam. Yes,
Yeah.
ma'am.
If the injury involves a punctum itself, supposing the tear is at the punctum, then what would be the option? Do we have to go for a bicanaliclar intubation or?
I think in that case, most of the times just suturing the punctum and just putting the stent generally works, because the collarate and the cylindrical part of the stent is going to make sure that the canaliculus or the punctal part is remaining open. So that can be one of the things, if that is the only place where the tear is there.
But either ways, I think the punctal, the sphincter effect is going to be lost. The patient might still have some epiphora in case the puncta is going to be involved. I would probably just choose Botox to the lacrimal gland. Easy.
Gland, or maybe a bicanalicular intubation, where some articles are given as bicanalicular intubation also. So probably that's an option.
Shall we go on to our next speaker?
Yes, ma'am. Yes, ma'am.
I would invite Dr. Aditi Pujari, who's a consultant at Sunayan Oculoplasty Center from Aster Aadhar Hospital, Kolhapur. And she's going to be taking us on a different part on trauma, periocular fracture, my approach. So on to you, Aditi. And you're truly thankful to Aditi. She's running high fever and still being quite a sport and giving her talk today. Thank you.
Thank you so much, Chitra madam and Dr. Vidya ma'am, for the opportunity. Is my screen visible?
Yeah.
Yeah. So I'll be basically taking through the periocular fractures, covering just the basics, because I'm sure next speakers are going to go ahead with more complex fractures and all the patient-specific implants and everything. So just the clinical things when we actually go ahead with treatment, and when we just leave alone the patient, these are the main things which I will go ahead. So before starting, we all know the bony anatomy of the orbit. Here, while talking about the fractures, we mainly need to know about the medial wall as well as the floor of the fracture, floor of the orbit, because these are the two common places where the blowout fracture is very common. Obviously, with a more forceful trauma like RTA or any forceful injury, even the zygomatic bone, the lateral wall as well as roof is also involved in many of the cases, especially where the trauma is very strong. So what do we evaluate in a patient who where we are suspecting fracture of, or we want to rule out fracture, what we actually see? So before starting any ocular evaluation, first thing, because I work in a multi-specialty hospital, many a times fresh polytrauma cases come. So first thing which we need to see is the GC of the patient. So the priority list wise, it will go about the GC of the patient, followed by the eye, followed by the vision. So that is a routine thing which we evaluate. So once we are confirmed that GC is fine, and if the patient is a cold case who has come to OPD, so we ask about the history, basic ocular examination, ocular movements, because we want to know if there is any restriction of the ocular movement, which can be due to either a nerve injury or can be due to the muscle injury or entrapment or muscle prolapse. Presence of any inophthalmos or sometimes even proptosis can be there in few cases initially when there is a hematoma or a lot of edema is there post-trauma. Then another thing which we need to see is infraorbital hyposthesia or anesthesia. because many a times the infraorbital nerve is going to get damaged. So we need to check that preoperatively. Sometimes while putting the implant or handling the floor, that can also get damaged. So we need to actually document if it is missing since the beginning or it has like got affected post-surgery. Then comes the malar flattening, which is generally because of the zygoma fracture, which is the loss of the malar prominence of the face, and obviously trismus or difficulty in chewing or the bite is not correct, which will involve mainly the lower part of the face, including mandible or the condylar fractures. So now when we see any patient, such patient is coming to OPD who we want to rule out or rule in fracture, what we need to see is most common features are superior sulcus deformity, enophthalmos. Many a times even with a gross enophthalmos, the eye looks slightly bigger when compared to the other eye. If there is a zygoma fracture, even the lateral canthal position is also disturbed if there is no other wound or any improperly sutured laceration is there. So because the soft tissue or the bony anatomy changes, so that is going to slightly change the lateral canthal position also. Another thing, again, with the muscle entrapment or prolapse, there is going to be some limitation of the movement in upgaze or maybe medial or lateral, depending on which muscle is actually involved. And obviously enophthalmos when the initial edema or hematoma, whatever is there, is settled. So when we actually order a CT scan, it is very important to order a proper CT scan where we want to order a CT orbit, which should include bony as well as soft tissue windows in axial, coronal, as well as sagittal cuts also wherever possible. So here we need to see what kind of fracture is there, whether it is involving the strut, what walls are there, is there any muscle entrapment or prolapse. So there is a difference between entrapment and prolapse. I'll be showing few cases of entrapment as well as prolapse. So I'll explain that during that. So these kind of patients who are like now cold cases or sometimes in children where we call it as white-eyed blowout fractures, they just have the entrapment of the muscle. So most of these cases will have very minimal enophthalmos but gross restriction of the movement. So these kind of restriction of the movement where the eye is absolutely not moving. So those kind of patients are most probably going to have entrapment and not prolapse. So here what you can see is the size of the fracture is not very big, but the tissue is prolapsed and the muscle is actually entrapped. So the prolapse is a bigger fracture. I'll just go back and show it here. So it's a bigger fracture. All the tissue along with the inferior rectus is prolapsed. So this patient is going to have some amount of elevation, but not a complete free elevation. So here we need to see if it is an entrapment or prolapse of the muscle. Again, now these kind of patients where you can actually observe the right malar prominence, which is flattened when compared to the normal left side. These patients most probably have a zygoma fracture. But if there is only zygoma fracture without any floor or gross medial wall fracture, the patient is not going to have any gross limitation of the movement or any gross enophthalmos. So malar flattening might be the only sign which is there in these patients because of the zygoma fracture. Again, while ordering the CT scan, it is very important to order for soft tissue as well as bone window. So now, in this case, where this is a coronal cut of the soft tissue window. So here, because of the window width and window level differences, you cannot actually make out if there is any medial wall fracture. But if the same patient we see on the bone window, you can actually properly see the fracture which is there, which is missed because of the soft tissue window. However, you can actually see the rounding of the muscle and displacement of the muscle, but the bony fracture may not be seen clearly on the soft tissue window. So you may miss few small fractures in case if you are just reviewing the soft tissue window and not bony window. But thankfully, most of these patients hardly have any restriction of the movement or in ophthalmos, because the fracture is such small that there is not much of prolapse or entrapment of the muscle or any other tissue like orbital fat. So these patients where you are actually able to see clinically gross in ophthalmos hypoglobus, but when you are actually seeing the CT, the fracture looks pretty not very big or greatly displaced. So it is very important to actually see the other eye also. Now, when you actually see the other eye, we actually get to know that the orbit has absolutely expanded. So the fracture fragments are uniformly displaced. So it doesn't show a proper teardrop sign or anything, but there is a gross increase in the orbital volume, which is causing gross in ophthalmos. So now coming to the treatment, do we treat all the cases? So now this patient was referred by ophthalmologist because this patient had trauma, got the CT scan done, and CT scan showed floor fracture. But even after resolution of the edema, patient never had any restriction or limitation of the movement, no diplopia, not much of inophthalmos also. So these kind of patients we can safely avoid any treatment because there is no symptom. What are we going to tell the patient? What symptom are we treating? We have done the fracture repair, but what have we cured? So these kind of patients, surely we can just observe if there is not much of cosmetic problem or functional problem like diplopia. Similar is the case here, even the fracture is bigger.
Doctor, 1 minute more.
Yeah, the muscle has prolapsed, but there is no restriction of the movement or gross in ophthalmos can be surely observed. This patient had in ophthalmos with the prolapse of the muscle, but patient was not much bothered about the inophthalmos. So unless it is a cosmetically concerning inophthalmos for the patient, we can just still observe if there is no functional deficit or any diplopia. So this patient actually came with sudden chemosis. He had history of some coconut falling on his head some 2-3 days back. And suddenly this developed the day when he presented. So on CT scan, actually, there was a small, again, medial wall fracture with multiple air pockets. So on asking the history, he had blown his nose and that had made the air enter the orbital cavity, which caused the chemosis. So there was a medial wall fracture. It was not very much bothering him because there was no diplopia, nothing else, but suddenly he blew the nose and then this entered and the whole problem started. So just I had instilled paracaine drops just to make sure that the eye is closing properly, and then just punctured those few bigger air blips, and the patient was doing well. No diplopia, no inophthalmos, again no functional deficit. So we just observed the case in these kind of patients. So it is very important to tell the patient in cases of medial wall fracture to avoid blowing of the nose, which is going to cause sudden proptosis or sudden chemosis because of air entry through the sinuses. So my criteria for surgical intervention: muscle entrapment or oculocardiac reflex. Diplopia mainly in primary and down gaze because those are the main functional gazes. Significant inophthalmos, which is generally more than 2 millimeters, any degree of inophthalmos which is bothering the patient cosmetically. Even if it is 3 millimeters, patient is not bothered, I generally go ahead with observation. My preferred approach is transconjunctival, which can be transcaruncular or inferior fornacial depending on which fracture I'm dealing with. But if there is any pre-existing scar or wound, we can actually go through it. Orbital rim approach is another one which many of the maxillofacial surgeons prefer. So again, this patient bothered about inophthalmos, not much of diplopia. We went ahead with fracture repair. This was a pure blowout fracture, no fracture otherwise. Gives a very good inophthalmos correction with the implant insertion and retrieving all the orbital contents again into the orbit. So this patient had actually entrapment. So here you can actually see there is not much of a bigger fracture, but the muscle is entrapped. So these kind of cases, we actually sometimes need to widen the fracture margins and avoid pulling the muscle, otherwise it will get broken, and then just put some barrier so that the contents do not prolapse into the maxillary sinus, and it surely gives a very good outcome because these patients are really bothered because of the diplopia with because there is a gross restriction of the up gaze. Obviously, these kind of bigger fractures need improvement, but sometimes we need to take care of some residual soft tissue injury like symblepharon, improperly sutured eyelid, which can be addressed at the same time when we are addressing the fracture in cold cases. So this patient, I'll just finish up with one or two cases. So this patient actually had a glass injury. She was wearing the glasses which broke with the RTA. So the rim, glass rim actually damaged it. So we did the lid tear repair, but obviously she had restriction of the movement in up gaze. So I generally prefer to wait for 2 weeks in these kind of cases where I need to know the degree of inophthalmos. She was also bothered about the lateral canthal angle, which was slightly displaced. So with this fracture repair, we went ahead with the lateral canthal reconstruction also. So the canthal angle was made symmetrical, fracture was addressed, and then she was very happy with the correction because diplopia was resolved and inophthalmos was also resolved. So these kind of patients, earlier, they'll surely have proptosis kind of features because of the hematoma in the eyelid or maybe orbital, but when it resolves, you can actually see the superior sulcus deformity, and then you can decide which kind of implant you want to use, what kind of volume augmentation is needed. So I'll just finish with this interesting case, which was referred as a for lid tear suturing. Patient had some injury because of some firecracker, and then to our surprise, there was a large foreign body which was seen along with the small medial wall fracture. And when we actually opened it, we were just trying to pull it on, and it came out to be something bigger because he had used some kind of firecracker, this thing inside this to increase the blow of that fracture. So it is very important in case we miss this and just suture the lid on this, we will miss the foreign body. So it is very important to suspect orbital foreign body even if the entry wound is absent or very small. So to just summarize, proper evaluation is absolutely important. Appropriate radiological and clinical correlation is important. Decide if the case actually needs surgical intervention. Rule out foreign bodies and counsel for realistic expectations, because not every fracture is going to get a perfect symmetrical appearance with the other eye or perfect appearance which was there pre-trauma, pre-fracture. So counseling is very important. Thank you so much.
Yeah, Dr. Aditi, that was such a wonderful talk. And Vidya, you take one question and we should move on. We'll be running late otherwise.
Yes, madam. Aditi, that was an excellent presentation. You had highlighted everything, all the whatever we wanted to know, you had highlighted. There are a few things that I want to know. What about the concurrent injuries with which affect the optic nerve? How do you
Vidya,
treat that?
could you direct the questions to our expert panel, keep them involved?
Yeah. Madam, not just to Aditi, all the expert members, please feel free to answer all the doubts or queries that I'm raising so that we have a good discussion on all the points. So I would like to know about the concurrent injury to the optic nerve. So how do you treat that? That's one point. Sometimes we also find in blow-in fractures, which is again a gray zone. How do you treat that? So that is along with the floor repairs and medial wall fractures, we usually deal with that. What about the blow-in fractures that cause impingement of the muscles, which can cause elevation restriction? So there are few cases where we had this kind of problem. So how do you deal that?
So for the concurrent injuries, like while evaluating, you'll obviously see some RAPD or some decrease in the vision. So in case there is no other injury and you are giving a very good antibiotic cover, I think it is worth giving the steroid trial if there is no direct impingement, and I assume that it is indirect trauma. And most of my cases, unless there is some concurrent maxillofacial surgeon who wants to chip in very early, I would prefer to wait till 14 days. So till that time, the optic nerve and everything will be taken care of because it needs to be taken care of in the initial period. So yeah, other people also, please.
Dr. Raguraj,
Um,
anything to
yeah,
add?
actually, the thing it spontaneously responds. So if there is a traumatic optic neuropathy, I wouldn't go in early. I would wait till it gets better. because you want the patient also to feel that his vision is improving, and most of them spontaneously improve. And if there's a traumatic optic neuropathy, I usually start them of IVMP because it serves a dual purpose. Of one is something to give so that the swelling and all comes down, and the patient also feels that his edema is coming down. And as spontaneously also the vision also gets better in many cases. So if there is a traumatic optic neuropathy at the same time, if the fracture is there, I would wait for at least a week before we intervene. Say I wouldn't go in early, even if there's a big cross fracture is there, I wouldn't go in early when there's a traumatic optic neuropathy. That's one thing I would like to add.
Dr. Vijay, you have anything to add before we go on to our next talk?
I think I'll just take one on the blow in fractures. So most likely, like if you have an impingement on a particular muscle, it's not causing anything gross deficit, you just leave it the way it is. But if it is actually causing an extraocular muscle restriction, you can just go in and you can trim the bone which is causing, if there is no gross ENOF or any other deficit, only for the release of the extraocular motility restriction which is there. So we've done that for roof fractures and lateral wall fractures, but I have never had a situation with medial wall or floor. And in fact, actually, blowout fractures are more protective mechanism. So, like Dr. Raghu said, I don't think so. If you have a traumatic optic neuropathy, we'd want to like wait a little bit. It's not an emergency. You don't have to go in and rush in like our dear MaxFax colleagues want to just do it. We can wait for some time and then do it.
In the end, you end up taking some of the blame for the vision loss if you go in early.
Exactly.
So yeah, so better to be safe. And I mean, it's actually psychological only. We're not going to harm anything, but it's always best is to wait for the swelling and everything to reduce before the patient, and then the patient has enough time to decide on the next course of action. Because if you just rush in and telling that we need to, they might think that we're going in to save her vision, save his or her vision, but actually it's not the case. We're actually only treating the fracture. Just by going in early, we're not actually treating the traumatic optic neuropathy.
Thank you. We go on to our next speaker, Dr. Preeti Uday, who's an orbital and ophthalmic plastic and reconstructive surgeon from DRR Eye Care and Oculoplasty Hospital, Chennai. And she's going to be talking on complexities made simple with navigational surgery and patient-specific implants. So on to you, Dr. Preeti.
Good evening to all of you. It's a real honor to speak on this, my favorite topic. And thanks, Dr. Chitra, for this wonderful webinar. So I would like to simplify this complex topic, which is navigational surgery and patient-specific implant. I have no financial disclosure. So when we talk about navigation guided surgery or patient-specific implant, here we are talking only about complex fractures. It is not useful for very simple fractures. So these fractures are complex, they are comminuted, and usually there is a secondary reconstruction involved. That is, the patient has had injury previously. There is malunion, there is bony callus formation, there is bony resorption. So it's a complex situation. And in these situations, we need to plan the case preoperatively. Now, about 10 or 15 years back, when we used to plan these cases, we used to make these kind of 3D skull models because we didn't have any other technology at that time. And we still make these models, but this was only available. This was the only thing that was available a few years back. So here now, first picture, you can see that the zygoma is malunited. You will feel that why not just move the zygoma and plate it? It's such a simple case, and why do you need technology? But what happens in these late cases is that there is malunion, there is callus formation. So this gap will be increased in some cases because of bony resorption. Sometimes there is new bone formation. So when you place the bone back, you don't know exactly where to place. The bone not only moves from lateral to medial side, but it also moves in this direction and it rotates. And this rotation is very important. Then only you will get this anterior projection in place. So for all these to be perfect, you need some kind of guidance during surgery or preoperatively. Also on these models, we could plan the surgery. Like in this case, there is a callus. So we remove the callus and we contoured the implant on this. And this contoured implant then we use for reconstruction. So when this implant fits well during surgery, you know that your reconstruction is complete. Now, a step ahead in the planning was using mirrored skull models. So here the patient's right orbit is injured. We have mirrored the left orbit onto the right orbit and made a skull model of that. And we have contoured the implants on this mirrored model. So these implants will be used during surgery. So during surgery, after you have reconstructed, if these implants fit well, you know that your reconstruction is okay. So these are indirect ways in which you know that you are doing well during surgery. But how exactly do we know that our implementation is correct? Now, that is where navigation guided surgery comes into play. So, navigation is like GPRS in the car. In the GPRS in the car, you know where you are located and you also know where you want to go, the direction also, and also your destination. So, same way in this navigation, you have an infrared camera on the console. You have this eye tracker, which is fixed on the skull model, and which is fixed to the skull of the patient. And you have this navigation pointer in your hand. You do the surgery normally as you always do. Whenever you're in doubt, you use this pointer and place it on that doubtful area, and you can see that area in the axial, coronal, as well as sagittal views on the pre-op CT scans that you have uploaded on the navigation platform. So it is as simple as that. You just have doubts during surgery, don't know which bone, where you are, how backward you are, how much bone is left behind. All that you can know by using navigation. And also in navigation, we mirror the other side onto the injured side. So you can use that mirrored image as a template for reconstruction. So this is how the navigation setup looks like. It takes about 15 to 20 minutes extra to set it up. And this is how mirroring works. So this orange line is the mirrored line. And when you're putting the implants, you should see that the implant coincides with your mirrored image so that you have some kind of guidance during surgery, because you don't have the other side exposed, other side bones are not available for comparison, and therefore intra-op navigation helps you. Also, you can virtually place your implants in the navigation platform, and you know pre-operatively itself whether this implant will fit well or not. So all this was useful some years back because this mirroring technology was available only on the navigation platform. However, now this mirroring technology is available even with the PSI companies, and therefore the use of navigation now in the current situation has become much lesser, because you can plan very well using the mirroring technology even without using intraoperative navigation. And if your planning is good, then your execution will be 100% good and you don't really need an intraop guidance. Now, in this patient, you can see that the size of the ready-made implant is not adequate for this patient, and this patient needs a patient-specific implant. So for patient-specific implant planning, we use a mirrored image, okay? So this mirroring technology you use with the PSI companies. You sit with them in Zoom meetings and various planning sessions we have, in which the surgeon can guide the manufacturer as to how big you want the implant, what is the size of the mesh that you need, where do you want the screws, what is the direction of the screws. All this can be planned, and you can design specific implants for the patient. Now in India, we have good patient-specific implants at reasonable cost available very much. Now, whenever you, as I told you before, navigation as well as PSI, you're going to use only for complex fractures, for secondary reconstructions. For localizing small bony fragments, navigation is useful, and also for bony reconstruction post-resection for malignancies. So if you see the entire indication, it is more for bony reconstruction and not for soft tissue reconstruction, because we are using the pre-op CT scan of the patient, and therefore during surgery, the soft tissue is going to move. So soft tissue guidance will not be good with navigation. So here you can see I'm touching the lateral canthus, and then you can see that lateral canthus on the CT scan of the patient. So similarly, you can see various bony landmarks during surgery. And also you can verify implant placement like this, that I'm running the navigation pointer over the implant once I have placed the implant. And you can see it is coinciding with the blue line, which is the mirrored image. So your second procedure rates reduce once you use navigation. Now, few cases like this patient has 3-wall fracture, floor, medial wall, and roof. He also has ptosis, he also has telecanthus. So here, if you just put a shell like this, prosthetic shell, it will look like this, because the foundation or the bony framework is not in position. So even if the patient has a non-seeing eye, if you want a good cosmetic outcome, you need to reconstruct the bony framework. So here we have used the skull model, we have recontoured the implants as well as used navigation. So 2 ways of checking that your reconstruction is adequate. And in these kind of cases, there is a big empty space between the medial wall as well as the floor. You won't know exactly where to place this transition zone between the floor and the medial wall. and navigation or pre-op planning helps you to do that. And once your reconstruction is perfect, your cosmetic outcome will be good. So it helps you to position the transition zone well in these cases. Now, another case where there is a malunion of zygoma. This patient has had surgery before, but you can see zygoma is still rotated. The floor is still fractured. So in this case, again, we have recontoured implants on the mirrored skull model and also use navigation. And you can see that the reconstruction is now perfect. So accuracy and precision increases when you do these kind of virtual planning. Now, another patient, very, very large gross enophthalmos, very large floor and the medial wall fracture. He also has had a reconstruction before. So this is how you plan for a PSI. You just sit on the Zoom meeting and then you plan the whole implant manufacturing with the manufacturer. And this is multiple sessions you have, so till you are really satisfied. This is one of the earliest PSIs in India that we had planned, and you can see on the screen it looks beautiful. But when you actually receive the implant, it's so huge, and it was very difficult to place this implant for this patient. And also the quality of the titanium, the quality of the surface polishing matters a lot in these kind of cases, because these are young patients where fibrosis is very high. And you can land up with orbital adherence syndrome if the quality is not good. So this patient, after the PSI, his enophthalmos improved, but he had a whole range of soft tissue issues. So he underwent about 6-7 surgeries, and finally we could bring him to this level. So you must tell these patients that they need multiple stages. I tell them definitely you will need 3-4 stages in the beginning itself so that the patient is prepared. Another patient who has a prosthetic eye, again, we have designed a PSI and also did his eyelid. So I do the bone as well as soft tissue together in most of the cases, except in the lower eyelid where I do it in 2 stages. Now, so the results are good. Now, another patient, you can see there is flattening of the midface, like Aditi was saying, the anterior projection is lost. Again, there is a zygoma fracture, but now his zygoma is itself deformed completely. So if you're going to break the zygoma and move it in place, somewhere or the other, the deformity will persist because the shape itself is altered. So in these kind of cases, we design an onlay implant. On top of this bone itself, you place another implant which is made of PEEK. So this green color is the PEEK implant that we have designed. And for the floor and the medial wall, I have used a pre-contoured striker implant, which is Medport coated. So I like to use these coated implants in patients who have had reconstruction before, who already have a plate inside. When you again go into this orbit, again, fibrosis is very high, and therefore Medport coated implants are much better. So this is how here I am drilling holes in the PEEK also, because I'm doing a mid-face lift along with the PEEK implant. So PEEK looks like this. It looks almost like a bone, and this is the Medport coated titanium implant. And you can see post-operatively, his mid-face has improved tremendously. He needs a ptosis correction, which we will do in the second sitting. Now, another patient, again, the mid-face is flattened here because the zygoma is malunited. He also had neurosurgery before. You can see all the 4 walls are fractured here. Again, we have designed a PSI for the rim, and the floor and the medial wall was corrected by Medport coated titanium implant. You can see the implant here, and this is how the PEEK looks like. Post-operatively, PEEK will not be seen on the CT scan, but titanium is seen well, and you can see the midface has improved very well. But this
Doctor, 1 minute more.
Yes. Yeah, and this deformity is there because of the temple hollowing, which we will do a fat graft later. Now, another patient, all 4 walls involved. What we have done here is not used any patient-specific implant, but we designed a drill guide for him. So this is the guide that we have designed. So this will guide you as to where the drill holes should be. And if the drill holes fall well in the correct position, you know that your implant is in the right place. Now, one more advancement is we have now designed drill guides as well as cutting guides by using this virtual planning. So this was the post-op result of this patient. Now, another patient, very, very severe trauma. He's had 4 surgeries in the past. The first surgeon has put a rib graft to correct the zygoma, but you can see that the zygoma is very much laterally displaced. Now here, the second surgeon, instead of moving the zygoma, has added a PSI here. So orbit has become okay, but his horizontal width has increased because the zygoma is out. So now here we need to break the zygoma, that is do an osteotomy and move the zygoma in place. But we don't know how much to cut and how much to move. So for that, we have designed a cutting guide. So these cutting guides are then virtually planned. These are made of titanium. We fix these cutting guides and then you cut the bone. And also this is the drill guide for the zygoma. And we first drill these holes and then remove these guides, cut the bone, move the bone to the normal position and use these patient-specific titanium plates. So this is another advanced planning where we are now having guidance even in cutting as well as in the drill holes. And this was the post-op reconstruction. You can see the zygoma now is back to the normal position, and also the orbit looks much better. And this is just 2 weeks post-op. You can see the mid-face has improved tremendously. We have not touched his eyelid. That I will do in the second sitting. So now another girl like this who has a very gross enophtalmus, she's had 4 surgeries in the past. So all these cases that I'm showing you have had at least 4 or 5 times reconstruction done already. But you can see posterior orbit, the volume is still very much enlarged. So now we are collaborating with a German-based company because I want a better surface of the implant for her. She already has orbital adherence syndrome. So this is the implant that now we are designing, and today only I finalized this plan. And here we also design the direction of the screw in which I'm going to put. So you can see this guide, the drill hole guides also available. So now with improved technology and also remote planning, we are able to access companies from different parts of the world and give patients a very, very good quality implants. There is increase in accuracy, predictability, as well as outcomes, and reduction in the second procedure rate. Of course, there is financial involvement, but if you see these very young patients, they are ready to pay because they have this deformity and they have to live with it for life. So we should have the entire package in our armamentarium, and we should be able to give them good cosmetic outcome if they can afford. And of course, it has a very steep learning curve. We've also learned over the years. Even the planning needs a lot of learning. And but we can now give good cosmetic results even for these very, very complex cases. Thank you very much for this wonderful opportunity.
Oh, it was a wonderful opportunity to hear your brilliant talk, Preeti. Truly amazing. Vidya, maybe we'll just take one question. She has given us a great information. We need to go on to our next speakers. Very good talk.
Thank you.
Dr. Vidya?
You're muted, I think.
Vidya, you're muted.
Yes. Thank you so much, madam, for that wonderful talk. I don't have personal experience in PSI or in navigational surgery. So you can consider these questions as very layman's question. What happens if our navigation fails when we are doing the surgery? These are like high-stake patients. Do we have any safety net in place? Do we have any backup data when we do this?
It's very common to have technology failures during surgery. We've had that, and we managed to do the case then without navigation. So surgical skills is the first important criteria when you take up these complex cases. And of course, you have to learn troubleshooting also. So when this happens, how you get back to normalcy, you should know a little bit of software. So you have to sit with the technician and learn that troubleshooting before you take up these cases. So we've gone through that learning curve. We had backup plans. But now that's why I showed you some cases where we have pre-contoured implant also. We have done the virtual planning on models also. Plus we use navigation. So that we have 2-3 backup plans. And you are rechecking your accuracy in 2 or 3 ways. So that way, I think you are saved.
Okay. And what about this PSI also, madam? Any material that we put in, they have the problems of compatibility issue. They have the problems of malalignment. Do we have the technique to modify the existing one, or do we have the opportunity to place a new one? What happens to those malaligned implants?
As I am doing more and more complex cases, I have realized that titanium, which we used to think earlier as inert, is not all the time inert. It depends on the surface irregularities, the aperture size. There are a lot of issues. I'm going to present this in AP Sopras this year. So the quality of surface polishing also matters a lot. So whenever you go inside the orbit, even second time, you will expect a lot of fibrosis. And we are doing a whole series of these patients where we have found the adhesions intraoperatively. We have even recorded it. And I have my strabismologist who is also working on this, whether it's the muscle fascia which is affected or how we can avoid these kind of adherence syndromes. So we have this issue very commonly. We have tried mitomycin, we have tried platelet-rich fibrin membranes to avoid all this, but still we face this issue because the patients are very young. They have tendency to fibrose a lot. So that's why now for whenever I go into the orbit second time, if they already have a plate and if I'm going in again, I prefer to have a smoother surface on top of the titanium. So Medpore coated titanium is a good option, but we can't customize that. So when you customize an implant, you get only titanium. So we are still working on all these issues that we have, but it is a very good idea to have a good strabismologist with you. They can really help you in correcting these small muscle imbalances post-operatively due to fibrosis.
Thank you. Thank you so much. We go on to our next speaker, Dr. Nandini Bothra, who's a consultant ophthalmic plastic surgery and facial aesthetics from LVPI Hyderabad. And she's going to be talking on management of post-traumatic duct obstruction. On to you, Dr. Nandini.
Thank you, Dr. Chitra and Dr. Vidya, for giving me this opportunity. Are my slides visible?
Yeah.
Yeah. So today I would be talking about traumatic secondary acquired lacrimal duct obstructions. So firstly, let us understand where the term SALDO comes from. So it was coined way back in 1992 by Bartley, where he divided the causes for secondary acquired lacrimal duct obstruction into 5 main types. That is the infectious, inflammatory, neoplastic, traumatic, and mechanical. And then he classified them into this exhaustive table. So actually, it's a disease. It's a type of lacrimal duct obstruction which can present in various forms. But today we will be looking at only the traumatic variety. And in that, what I would be talking about are post-traumatic canalicular fistulas, hardware-associated lacrimal duct obstruction, or what we call as HALDO, and what is the importance of CT dactyocystography in management of these cases with SALDO. So first, let us come to the first objective, that is the post-traumatic canalicular fistulas. Now, this term was introduced in 2013 and can happen because of either primary or iatrogenic trauma. Now, it is a very distinct entity, but it is highly unrecognized. And more so, we do not know what to do with these cases when they present to us. We know that around the canaliculus and the puncta, we have the honor duonis muscle. Now, this muscle is so tightly adhered around the puncta and the canaliculi that any injury to the canaliculi or the puncta will cause injury to the honor duonis muscle, and that will in turn affect our lacrimal pump function. So let us discuss this with a few case examples. So this was a 33-year-old lady who presented to us with complaints of occasional epiphora in the left eye since 6 months. So we probed the history, and then we got to know that she had undergone incision and curettage for hordeolum in that eye, which was followed by a lower canalicular intubation with mini Monoca stent elsewhere. Now, on everting the eye, if we closely look at the area of the ampulla, that is the junction of the vertical and the horizontal canaliculus, there is an opening which is present. Now, this is what we call as the post-traumatic canalicular fistula. So probably while doing the incision and curettage, the incision was made in that area and it accidentally cut through the ampulla of the canaliculus. Now, here what we did was we passed a probe through the puncta. It was giving a hard stop, of course, after passing through the fistula. And then we passed a probe again through the fistula and it was giving a hard stop. We did irrigation from both these places and the irrigation was patent. So now we have the option whether to go ahead and put a stent and do suturing in that area and repair it, or just leave it. Now here the patient really complained of only occasional epiphora, which was quite manageable. So we just observed this patient and we asked her to come back to us if the epiphora was troublesome and if she wanted any intervention. Similarly, this was a 32-year-old gentleman who presented with watering in the right eye since 3 years. Now, he had a history of trauma 3 years ago, which was followed by right lower lid reconstruction, which was done elsewhere. Now, if we look at the picture, we see a nice telecanthus. And if you look at this place, which is medial to the medial canthus, you will see a fistula in this area. Now, on everting the lid, the puncta was in the normal position, but medial to the puncta, there was another opening seen in the canalicular area. Now, when we passed a probe through the puncta, it came out from this fistula, which was situated medial to the puncta. So this had formed a canalicular fistula, but on probing through the fistula, the problem was it was a blind end. So we couldn't go in through the canaliculus. When we tried to pass the probe or do irrigation from the upper canaliculus, there was a mid-canalicular obstruction. So here we have a case where there was a right lower post-traumatic canalicular fistula. There was a medial canalicular fistula, which was very much visible. But again, there was no discharge or watering from this fistula. And from the upper canaliculus, there was a mid-canalicular block. So here we are dealing with both the canaliculi, which are completely destroyed, but there is no discharge or watering from the medial fistula. So here we can avoid a lacrimal intervention entirely. If the patient is symptomatic, the only option that we are left with in this case is a lacrimal gland targeted therapy like a Botox or a needling, which can help reduce about 20 to 30% of the epiphora. The second way to deal with this is a conjunctival DCR with Jones tube, or if the patient is not very symptomatic, we can just observe these patients. Now, this again was a 6-year-old child who presented with watering and discharge in the left eye and a fistula medial to the medial canthus here. He also had a history of injury. Now, since he was a child, we took this child under anesthesia. There was an upper and a lower post-traumatic canalicular fistula, and there was a fistula which was medial to the medial canthus. Now, if you want to differentiate it from the previous case did not have any discharge that was coming out from the medial fistula. But this child, on pressing the sac, had copious discharge that was flowing out from the lacrimal fistula. So now when you have such a patient, you have to go ahead and do something for the sac. Both the canaliculi are destroyed here with a PTCF. So we cannot do anything to the proximal lacrimal drainage passage. So we would only be dealing with the distal lacrimal drainage passage, that is the sac or the nasolacrimal duct. So here again, we are left with only two options. One is to go ahead with a conjunctival DCR with Jones tube, or do a DCT in this case, so that the discharge can be taken care of and we can prevent further episodes of acute dacryocystitis. So similarly, this was a 20-year-old male who presented with occasional watering in the left eye for 2 years, and that was post-RTA. He again had multiple post-traumatic canalicular fistula. However, he was patent from the upper PTCF, and he had complaints of only occasional epiphora, and therefore we decided to observe this patient. So any PTCF, we have to do a tailored approach based on the nature and the location of the fistula, age and the symptomatology, damage to the surrounding structures and the lacrimal apparatus, and the status of the canalicular outflow and the lacrimal pump function. Now coming to the second objective, that is hardware-associated SALDO. So this was a 25-year-old male with a history of road traffic accident that happened 2 months back. Now he underwent a maxillofacial repair 4 days ago following trauma and a vitreoretinal surgery 1 month ago. And then he presented to us with complaints of epiphora since a month. Now, if we look at the picture, he had RHO+ positivity, which is why he presented to us. But apart from that, there is significant enophthalmos, telecanthus, acquired epicanthal fold. There is periocular scarring, as we can see in the upper eyelid, and a depressed nasal bridge. So we went ahead and we did a CT-DCG in this case. So what do we see here? So if you look at the anterior coronal cuts, you see that there is a orbital implant which is placed, which is actually piercing the medial wall and getting into the ethmoid sinus. If we look at the axial cut, we see that the orbital implant which is placed is not actually hugging the medial wall, but is actually shifting the globe temporally. But what is of interest is, look at the left-hand side. You can see a nice nasolacrimal duct. So, of course, exactly opposite that would be your right nasolacrimal duct, and you can see a screw which is piercing through the nasolacrimal duct. Now, when you look at the 3D CT-DCG image, you can see that in the left, on the right-hand side, the lacrimal sac is nicely filled with the dye here, but just below it, you can see that the medial portion of the orbital plate which was placed has actually cut off the area between the sac and the nasolacrimal duct, which has probably resulted in the SALDO. So this is what we called a hardware-associated nasolacrimal duct obstruction or a lacrimal duct obstruction. So here, when we went ahead, we did a nasal endoscopy. And if you remember on the CT scan, we could see a nail piercing the nasolacrimal duct. And this is what we saw on nasal endoscopy. So we went ahead with a routine incision that we take for DCR. We first retrieved the screw from the implant, and then we removed the medial portion of the implant and completed the surgery with an external dacrocystorhinostomy. This patient did very well at 6-month follow-up. This was a 74-year-old lady who complained of watering and discharge from both eyes 4 years following surgery. So this was also post RTA, which happened 4 years ago, and she underwent a maxillofacial repair. She was Roplas positive in both the eyes. So we went ahead and we did a CT-ECG. Apart from multiple orbital fractures, when a maxillofacial repair was done on both the sides, the plates are actually right in the area of the lacrimal sac fossa. On the right side, we can see the screw was piercing the sac duct junction, whereas on the left side, we can see that the plate was completely placed just below the lacrimal sac in the lacrimal sac fossa. These are the parasagittal cuts which show us that the sac has been displaced from its position because of the underlying plate. So we went ahead. Now, this was a 70-year-old lady. Of course, there were a lot of systemic comorbidities. So we went ahead with an incision that we take similar for a DCR. We opened up the sac, and what we saw was within the sac, we can see the plate, and the sac architecture was completely destroyed. There was no bone over here to actually punch and do a DCR. So we went ahead and did a DCT on both the sides. This was a 24-year-old male who presented with a road traffic accident 2 months back. He had undergone a maxillofacial repair, and then post the repair, he had epiphora. Now, he was Roplas positive on the left-hand side with significant enophthalmus. We can see a nice telecanthus in this area and scarring. We again went ahead and did a CT-DCG. You can clearly see that this is the sac, and you can see a screw which is piercing the substance of the sac. So in this case, when we opened up the sac was completely damaged, and there was nowhere that the probe was actually coming out safely into the sac. So we had to go ahead and do a DCT in this case. However, this 22-year-old male had a similar kind of finding, but when we opened up the sac, you can see that the implant is very much on the posterior part of the sac, and the probe is coming in from the anterior aspect. You can see the stent here coming in from the anterior aspect of the sac. So because the implant was very far away from the common canaliculus, we went ahead and we did a DCR, and he did very well at 1 month follow-up. So to conclude, hardware-related saldo can cause direct tear of the sac by the fixation screws. CT-DCG is very, very helpful in these cases to understand the spatial relationship between the implants or the screws that were placed and the lacrimal apparatus. And this thorough applied knowledge of lacrimal anatomy should be a part of every maxillofacial surgeon's armamentarium to avoid inadvertent lacrimal trauma during repair. Now, coming to the last part of our presentation, that is how important is CT-DCG in cases of traumatic saldo. So now let us look at this 20-odd-year-old male who presented to us after an RTA with a swelling like this. So on syringing, of course, there was complete regurgitation from the opposite punctum. We went ahead and we did a CT-DCG. What do we see on the 3D cuts? We see a nice outpouching from the lacrimal sac, which is suggestive of a huge lacrimal sac diverticula. If you look at the parasagittal cuts, you can see that the sac is completely dilated with obstruction happening at the sac duct junction. And you can see a nice outpouching which is developing anterolaterally. So now what does CT-DCG tell us in this situation? One, that an endoscopic repair should not be preferred because the diverticula is anterolateral, and it will be very difficult for us to deal with this diverticula if we do an endoscopic procedure. We should actually proceed with this surgery externally and make sure that we take out the diverticula completely during the surgery when we do a DCR in these cases. Now, this was another girl who presented to us post-RTA. Look at the left side. You can see a nice telecanthus, and you can see that the lower lid is slightly displaced upwards. So we went ahead, syringing was showing regurgitation from the opposite punctum. We went ahead and we did a CT-DCG. Now, in the 3D cut, what you can see is an underlying orbital implant, which was done elsewhere. And then you see a nice dilated lacrimal sac. But what is characteristic of this lacrimal sac is it is very much dilated and it is slightly displaced laterally. Now, 3D reconstructed images give us much more information than we actually looked for. So now when we tilt this image, you can see that the lacrimal sac has actually moved back or posteriorly into the orbit. This is the lacrimal sac fossa here, and the sac has actually moved posteriorly, and we could see in the anterior cuts that it had also moved anteriorly. So there was laterally. So there was a posterolateral displacement of the sac in this patient. Similarly, if we look at the right side image, you can see that the sac is very much in position. And if you compare it to the other side, that is the affected side, you can see that the sac has moved posteriorly into the orbit. So again, what this tells us is, again, an endoscopic approach should not be preferred because you would be searching for the sac in the lacrimal sac fossa, but actually it has moved back into the orbit. If we actually go ahead and do an external approach, we can pull the lacrimal sac back to its position and create a flap and fix it to the nasal mucosa. Now, this was another patient who presented to us post-trauma. Now, what do you see here? You see that the glabellar region is injured in this area. There is a depressed fracture in the glabella. Along with that, you see telecanthus, you see a flattened nasal bridge. So we went ahead, did a CT-DCG. You see that there is a lot of injury on the 3D cuts in the forehead area. Now, when you look at the coronal scans, you see a lot of injury in the cribriform plate area, and you see that there is a low-lying cribriform plate in this patient. Now, when you do a CT-DCG, it helps us to understand what is the relation of your lacrimal sac with respect to the cribriform plate, because that is very important in cases like this. If we go overboard with creating an osteotomy in these cases, we may end up with a CSF leak or even herniation of the brain contents into the created ostium or into the nose. So we need to understand what is the relationship of the sac with respect to the cribriform plate. So here, if you look at the left side, you see that the sac is migrated slightly superiorly. Now, what helps us in this situation are these cuts, which are called the MIS sequence or maximum projection intensity sequence, which you can ask your radiologist to provide to you. Now, this will remove all the artifacts and will give you what is the exact relationship of your bony landmarks with relationship to your lacrimal sac. So here we will not go all the way up to the fundus of the sac when we are creating an osteotomy, but we will rather create an oblique pathway and stay slightly inferior to the fundus of the sac when we are creating an osteotomy. And this case would be best done endoscopically to understand where to stop doing your osteotomy. So hence, to conclude, CT-DCG effectively helps us to guide the management of traumatic saldos. It facilitates the choice of surgical approach, whether we want to take an external approach or an endoscopic approach, or in certain cases where the damage is too much to the surrounding structures, we can even decide to go ahead with a DCT. It provides us vital clues in order to avoid intraoperative surprises, and it offers a better preparedness for surgical challenges. Thank you.
Oh, that was again another wonderful talk. Vidya, just a brief question.
Yes, madam. Yes, madam. Wonderful talk, Dr. Nandini. I had so many learning points from this, the PTCF and the CT-DCG, and wonderful case series on everything.
Thank you.
The low-lying one was very, very good. So I know like you do lots of, I think you do exclusive endoscopic DCRs, right?
Yeah.
And what is your preference for external DCR in case of traumatic setting? You had mentioned few, but how do you actually decide when to do endoscopic or when to do external? Is it always based on CT-DCG?
Yes.
or your routine probing syringing also helps? How do you do that?
So in my practice, I prefer to I prefer to do endoscopic dacrocystorhinostomies. For Pando, it is a no-brainer. We just go ahead and we do um an endoscopic DCR. But where traumatic cases are concerned, we have to we have to see whether the sac is in its position, whether the surrounding anatomy is conducive to a repair. So in my practice, a CT-DCG is a must where traumatic cases are concerned. I do not go ahead with surgery directly without a CT-DCG. We have trained our radiologists, which is right across our center, to do a CT-DCG, and they give us the cuts that we require, and then we go ahead and plan surgeries. Now, certain patients who cannot afford a CT-DCG, because of course, I have the advantage of practicing in an institute. We tend to try and make it free of cost for them and before actually going ahead with the management. But a CT-DCG for us is a must in traumatic cases. You're muted, Dr. Vidya.
Dr. Vidya.
So if you have problems with CT-DCG as in posteriorly placed sac, then you decide about external.
Yeah.
If not,
So
then you go ahead with it.
Yeah. So any migration of the sac, like a posterior which is displaced into the orbit, or lateral, like many a times you have a gross hyperostosis of the bone in that area because of fractures that have happened, like NOE fractures which were present because of the prior trauma. So in those situations, it is very difficult to actually go ahead and drill endoscopically. So I would prefer to do an external DCR where there are dislocations of the sac, where there is hyperostosis of the bone, where there are cases with diverticula, or where there are cases with extensive naso-orbitoethmoid fractures.
Okay.
Thank you.
Thank you.
We
Thank
go
you.
on to our next speaker, Dr. Tarjini Vivek Dave, who's Associate Director, the Ophthalmic Plastic Surgical Services at LVPI Hyderabad. And she's going to be talking on post-traumatic and ophthalmos challenges and outcomes. So on to you, Dr. Tarjini.
Yeah, thank you, Vidya. Thank you, Dr. Ramamurthy. I hope I'm clearly audible.
Yeah.
Right. So we'll move on. I've been tasked after these brilliant talks to speak about something that's, in my opinion, much simpler compared to what we've seen today. I have no financial disclosures to make, and you will see some full face photographs of my patients, for which we have the consent in place. I'm going to talk to you a little bit about what is an ideal socket, and then quickly jump into what are the concerns post-trauma in an anophthalmic setting. And then when you get into reconstruction of these sockets, what do you do in terms of replacing the volume? What do you do in terms of replacing the surface area? Finally, how can you give that Midas touch with the help of an ocular prosthesis? And what are the advances in this field? And eventually summarize with the help of certain case scenarios that I'll be showing you today. Now, this is one girl who's had a firecracker injury, and she has a left thusical eye, as you see in panel A. And she obviously had suboptimal volume due to the thusical eye, which required us to remove the eye with an evisceration. Obviously, this patient does not have vision on that side. And then we've crafted, fabricated, and placed a prosthetic eye on that side. And you see that she looks much better compared to the preoperative outcome or the preoperative situation. And therefore, an ideal socket is one where you have optimal volume correction, you have very good surface area which houses the prosthesis, you have an excellently crafted prosthesis, and you don't have any eyelid anomalies over it. So just remember these four terms: volume, surface, prosthesis, and eyelid. This is what gives a very good outcome for any anophthalmic socket situation. Now, when we are talking about trauma, there are two situations in which an ophthalmic plastic surgeon would be called in terms of the anophthalmic socket, scenario. One where a primary globe repair has been done, and following that, unfortunately, the patient has developed a thusical eye and now seeks cosmetic improvement. You may have a whole lot of associated soft tissue issues that this patient may also have, or you may be called on table for a badly ruptured eye and open globe injury where a primary salvage is not possible, and then you need to take over and perform a socket surgery. So I'm going to just show you a case example of both these situations. This is a patient who had a very badly traumatized right eye, and nothing was salvageable here. The entire uveal tissue and ocular contents were out. You can see that on the CT scan, the globe is completely deformed on the right side. And here there wasn't much to repair, and this patient had to have a primary mutilating eye surgery, such as an evisceration on table. Now, this is another child in whom we've repaired an open globe. We've also repaired an eyelid laceration. But unfortunately, the severity of trauma at times may be so much that the eye over a period of time goes into phthisis. Not only phthisis, you may also have some amount of fractures around this phthysical eye. And then these are two situations that need to be corrected to bring back the cosmesis for these patients. So what is your choice of surgery? I'm showing you a collage here of a patient who's undergoing an evisceration. And typically in situations of trauma, you're very certain that it's not an intraocular tumor or a suspected intraocular tumor. And therefore, most of us would go ahead with an evisceration surgery, where what you do is you remove the contents of the eye, you scoop them out, and then you fashion the sclera into petals. These petals are supported by extraocular muscles, and therefore they aren't free grafts, but they're rather flaps which are also disinserted from the optic nerve posteriorly and come and give you a tension-free closure on top of the implant, which is introduced here, over which the petals of the sclera are closed. And finally, that is how your immediate post-operative appearance is. I thought it'd be good to show a surgical video of this. So what you're seeing over here is some amount of retrobulbar anesthesia being given. This also helps with some amount of hemostasis in these patients. And I also like to inject a little bit of subconjunctival local anesthetic with adrenaline, which kind of, blanches the conjunctiva out and makes your surgery a little cleaner. What you then progress towards is to perform a complete peritomy 360 degrees, and then you dissect in the oblique quadrants, as you're seeing over here, all the 4 oblique quadrants. This is in preparation for your sclerotomies later on. It is to release the posterior tenons from the sclera. Once you've done that, you excise the entire corneal button at the surgical limbus, and then scoop out the intraocular contents. Essentially, in a traumatic eye, this is a fairly easy step, but this particular recording is of a patient who's had a vitreoretinal surgery, and in such situations, you often have adherence of the uveal tissue to the sclera, and it takes quite a bit to remove it. Once that has been done, you wash the scleral cavity with alcohol, which denatures the uvea and therefore avoids sympathetic ophthalmia, and you wash off that alcohol very thoroughly. Now, here's the important step. In 2 oblique quadrants, you go right from the limbus posteriorly, and just a little short of the optic nerve, you perform radial incisions. Eventually, around the optic nerve, you disinsert the sclera circumferentially. So you've made 2 flaps here instead of the 4 flaps which I showed you earlier. And this allows a larger diameter implant to go in and allows a tension-free closure of the sclera, so that you don't have to worry about implant exposure in the post-operative period. Once you've placed your desired choice of implant inside, you simply go in and suture the wound in 3 layers. The sclera is the first layer. The anterior tenons is the second layer, which is being sutured here. And finally, you close the conjunctiva. We tend to use absorbable Vicryl 6O sutures for all these 3 layers. The conjunctiva typically is the only layer which we suture in a running fashion. The others are with an interrupted Vicryl suture. So here you see the conjunctiva being closed. And once this step has been performed, you can go in and give some amount of retrobulbar anesthetic again, because this is a painful procedure. And this animation shows you what you achieve at the end of the surgery. You may want to insert different types of implants. Now, this is a small tweak where you use an introducer to insert what is known as a porous implant. Just like you have a multitude of IOLs, even evisceration surgery comes with several implants that you can place. There are several complications that can come up, and they depend on the type of the implant. Nonetheless, we'll not be discussing those complications today. What I wanted to highlight is sizing of the implant is good, and 70% of your volume needs to come from the implant, and the remaining 30%, which is lost because of losing that eye, should come from the prosthesis. We've gone through this animation. I just wanted to, bring out one point that certainly making these petals doesn't mean that the implant can now migrate into the different quadrants of the orbit, and that is a myth. Making these petals and placing a larger implant is the standard of care today. Now, what do you do if volume replacement is suboptimal? For instance, look at this patient preoperative here. He's had an evisceration surgery earlier and wears a prosthetic eye. He's not happy. Why is he not happy? Because of this sulcus deformity. And that is a sign of volume loss. That means he's not had enough volume replaced in that anophthalmic socket. And in such situations, you can simply go in and put another implant, which is well sized. And you can see that the sulcus builds up beautifully, and even the ptosis corrects on its own, just because you've given back the volume and the eye does not look enophthalmic like it looked in the preoperative picture. If you already have an implant, but that is smaller in size, instead of going in and touching that socket again, what you can do is simply transfer some fat from the patient from another area, say the abdomen or the buttock or the thigh, harvest that fat, and that fat is what has been injected. You see this sulcus deformity in the preoperative picture with a little bit of enophthalmos, both of which have been corrected by harvesting fat from the patient's own abdomen and transplanting it into the sulcus and also into the orbit. Sometimes patients are fussy and don't want a surgery, and in such situations, injecting a hyaluronic acid gel filler also does the same trick. You see an elderly gentleman here who's not very happy with his superior sulcus deformity, and all I've done is inject a filler in him. That's the point of injection. This is the immediate post-operative picture, and you can see that beautiful buildup in the superior sulcus. Certain times you may have situations where there was a fracture which was not repaired and only a socket surgery was done, and then the prosthesis will eventually have a hypoglobic appearance if the floor was fractured. And in such situations, you can go ahead and repair that fracture. I've introduced a Porex wedge implant along the floor where the fracture was. No eyelid surgery done. This helps bring back the volume inside the orbit, symmetrize it to the other side, and then the prosthesis obviously will look much better. Now, what do you do if you don't have surface area that houses the prosthesis? So from the eyelid margin to the opposite eyelid margin is your surface, and that area has to be adequate. And what's a measure of adequate surface area? So you should be able to see the patient being able to animate completely. When he closes his eye, there should be no lag of ophthalmos. The prosthesis should be able to sit comfortably and should be able to move comfortably, and that is an ideal surface area. And you see here a lady who had volume as well as surface loss and a prosthesis that was not filling with entropion of the lids coming up. And what I've done for her is in one sitting, replace the volume with an implant and the surface with a mucous membrane graft that has been harvested from the lip. And she certainly looks much better. Her lower eyelid has come back in position. She has a little bit of ptosis, which can always be corrected and is a very minuscule thing. Here you see another lady who has similar surface loss, not very happy with the prosthetic eye. And in her, I've harvested a hard palate mucosal graft to give the surface area back in the eyelid and act as a spacer graft, and therefore also correct the entropion that she has. And here she is looking much, much, much better than what she was preoperatively. I wanted to touch upon a few things related to the prosthesis. Now, this field has, seen a quantum leap forwards, and what we can do is craft a prosthesis based on the image of the contralateral normal eye, take very high resolution slit lamp photographs of that eye, do some photoshopping on it, and incorporate that paper into the prosthesis, which is crafted for the other eye, to make it look exactly similar and very, very lifelike. And this is something that our ocularists are able to give us. Yet another thing is PMMA, which is the material which makes the prosthesis, is very hydrophobic. And sometimes these dry spots give it a very lifeless appearance. And what you could simply do is treat these prostheses in the machine, which also gives the surface finish to contact lenses and intraocular lenses. And with that, improve the wettability of that PMMA, have a more uniform tear film over the prosthesis, and therefore have a much better looking prosthesis. There's a lot of work on 3D printing a prosthesis directly by using patients' radiology. This is also something which is exciting, especially for patients who are at a distance and cannot travel to you for making a new prosthesis. Just the last bit on giving back that final touch of aesthetics. So here you have a good socket surgery done, good volume replaced, a tad bit of ptosis, which can easily be corrected with ptosis surgery, or a tad bit of filler, as in this patient after the socket surgery. You see that not a very well looking eye. We've done a surface and volume reconstruction, looks better but not perfect. To make him perfect, we built up the fat here and also filled up his tear troughs, and you see that he looks much better after the little bit of touch up with a filler over here. In essence, I've spoken to you about an anophthalmic socket where you think on lines of giving back the surface and volume, assess the prosthesis, and enhance its aesthetics by whatever means that you have available to you. Thank you so much.
Thanks so much, Dr. Tarjini. I mean, it's been one amazing talk after the other. I think this really worth publicizing all over for the kind of talk you're
You're muted, Dr. Chitra.
Oh, muted? Can you hear me now?
We could, yeah.
Yeah, that was a lovely talk, Dr. Tarjini. We shall, any question, Vidya, because we have 3 more speakers.
No, I think Tarjini had done a wonderful job, covered everything possible in processes, and she has brought out all the newer things like the 3D printing and the wettability, wet processes. Those are the new things that are happening in the prosthetic world, and that's exciting to know all the new things. Thank you so much, Tarjini. Thank you.
Thank you.
We go on to our next speaker, Dr. Kavita Ramakrishnan, who's going to be talking on emergency management in ocular trauma. And she's a senior consultant from the Arvind Eye Care Systems. And she's going to be taking the talk on managing luxated globe. On to you, Dr. Kavita.
Yeah, thank you, Chitra ma'am. Thank you for this wonderful webinar and for the invite. Today, I'll just talk about one emergency situation which we have faced. Yeah, this is about a 2-year-old child who presented with a history of fall from a bike 3 hours back and accidental injury to the right eye after impact with the bike handle. So the globe was luxated with lag of thalamus and dilated fixed pupil and restricted eye movements. And the child was brought to our emergency and child was uncooperating for vision recording. Ultrasound revealed stretched optic nerve with no obvious retrobulbar hemorrhage. CT was done. CT imaging revealed a deviation in the course of the optic nerve with 3 septal air pockets. There is no evidence of intraocular foreign body. Hence, we plan for immediate reposition of the globe under general anesthesia. So this is the video clipping of this case. So after ruling out globe injury under general anesthesia, the upper eyelid was lifted and pulled over the globe using a Demar's lid retractor, simultaneously pushing the globe posteriorly into the orbit to reposit the eyeball back in place. A lateral tachography was done over bolsters with 6/0 silk suture to restrain the reposited globe in place. The chemos conjunctiva was also replaced. As the risk of retrobulbar hemorrhage cannot be ruled out, can be expected in these cases, a lateral canthotomy with cantholysis was done, and some amount of blood was extruded and let out of the retrobulbar space, as you see here. An indirect ophthalmoscopy was done, which was suggestive of a central retinal artery occlusion. Anterior chamber paracentesis was done for this child with a side port knife with gentle globe massage. A medial tachography was done to stabilize the globe. So this was how this patient was managed. So what is globe luxation? Luxation of the globe is a rare condition and it carries a risk of permanent visual loss. So in my career here for about 12 years, I have seen around 4 cases of globe luxation. So it's quite rare. So lucky to see 4 cases. The luxation of globe is defined as a forward displacement of the eye so that the lids close behind and not in front of the eyeball. So luxation occurs when the equator of the globe is allowed to protrude anterior to the eyelid aperture. The orbicularis muscle contracts either voluntarily or involuntarily, which causes further anterior displacement of the globe, and the globe is caught outside the lid aperture. So this is what happens in a globe luxation. So actually there are 3 categories: spontaneous, voluntary, and traumatic. So we are talking about a traumatic globe luxation which occurs after direct trauma. The trauma could be trivial or it could be a serious injury. So this is an emergency. It is often associated with optic nerve injuries like avulsion or orbital fractures. And as in our case, there was a CRAO. Trivial injury following impact with bike handle is common. So in the cases that I have seen, three cases had bike handle injury. Only one was a massive RTE. So the mechanism in a bike handle injury is attributed to the obtuse structures of the eyelids, so that when the bike handle strikes the upper orbit, the intraorbital pressure will increase, which will push the, while the eyelid is pushed back. So this pushes the orbital contents anteriorly, and using the orbital apex as a fulcrum, the luxation of the globe occurs. A pre-existing weakness of the extraocular muscles and its ligaments and shallow orbits have all been proposed as an etiology for globe luxation. So prompt recognition and repositioning of the luxated globe is essential. Optic injury is most common association. Anatomical restoration in ACEs is achieved if immediate action is taken. So this was the patient with an RTA. So if you see in this case, the globe has completely, it has been abducted. So this is the cornea. This is the cornea, and this is the stump of the medial rectus, which has got torn off, and the whole of the eyeball was extorted and it was luxated, and with a very bad fracture. So this required multidisciplinary approach, and we had to refer the case. This is reference articles. My colleague in our institution, this was the first case we saw. So this child was around 12 years old, and she came with bike handle injury. And she came to us immediately after the injury, and the globe was represented in a similar manner. And luckily, the child got back her vision. Vision was restored. And there's another article which says the vision can be restored if immediate care is taken and no other associated injuries. So detailed history, mode of injury is important, and recording and documentation with pictures of the patient and the eye is important in such cases. Check vision, and documentation of the vision is of course important. In case of poor vision, always check PL and PR should be checked and documented. Check for the pupillary reaction, and that also needs to be documented. And imaging CT scan should be done if necessary, MRI scans. Explain guarded and or nil visual prognosis to the patient and the attenders, and complete the consent forms. Immediate eyeball reposition in the theater is very important. So if it is happening from remote locations for a general ophthalmologist, document history, again, vision, pupillary reaction, and extraocular movement should be documented. In case for need for referral, document the vision and send the patient. Check the IOP and BP. Apply copious lubricating gel in order to protect the cornea. It's a good idea to patch the luxated globe with a sterile shield and not a gauze or pad, so that there is a space between the eyeball and the shield. Anti-inflammatories can be started, and refer immediately to the nearest tertiary center. Thank you.
Thank you, Dr. Kavita. Again, a wonderful talk. Just one comment from our expert panel. Dr. Hegde or Dr. Roshmi, any one of you? Any comment?
Hello. Yeah.
Yeah.
Just one thing. Is there any way, like these cases, you don't see them very often, and if they've had an episode earlier, and they're more prone to have another episode sometime in the future, is there any way to prevent future occurrence like this?
These were only traumatic cases which we saw, and none of these cases came back with a luxation. So it was trauma. Maybe you're talking about spontaneous
Yeah.
cases where they will have to.
There are some patients who have shallow orbits, like
Yeah.
it's like congenital orbits. They're not like these patients who have crozons or something like that.
Yeah.
But they have very shallow orbits, and occasionally they have a episode of luxation. So, is there any way to prevent them from happening, or since it's rare, we just wait and whenever it happens, we just reposition it back, or just.
Yeah, I think repositioning has to be done immediately. And these cases, and maybe if they have one episode, then probably actually there's one article where the spontaneous luxation, the patient themselves are able to reposit it back, especially with the voluntary luxation, they're able to reposit back. And the other thing is probably we'll have to identify the inciting causes and try to avoid the causes. So that would be good. And
So the one patient of mine who just when he just did this and it would just luxate out.
Yeah.
Just lower the lower lid, just rub a little bit and it would just luxate out. So I was wondering if maybe a lateral tarsorrhaphy or something.
Yeah.
That would
Have
probably.
you done? That patient? Have you done a tarsorrhaphy?
I'm contemplating, because if he's having very frequent episodes like that, I was thinking whether he should do it or not.
The only thing is cosmesis, they should be willing for that. And some amount of the lateral field, there's disturbance in the lateral field.
So I had done a tarsorrhaphy in this kind of craniostenosis, a patient with craniostenosis having a shallow orbits. As a prophylactic measure, yes, I have done a lateral tarsorrhaphy. But sometimes bony reconstruction would also be an option for these patients. Like if they can enlarge, as they do for decompression, they can enlarge the bony size, and that is also an option. It's what I read when I was doing this.
So one other option could be a wedge for the cheek implants, which would actually increase the malar area and reduce the inferior vector. So that could be one of the options that we could consider. But I mean, I have waiting for the patient to come back with another episode. If they're at that point, you can probably suggest him. That might be a better option than just
doing a torso. Yeah.
Absolutely, yes.
Thank you. We go on to our next speaker, Dr. Maya Hada, who's Assistant Professor, Department of Ophthalmology at SMS Hospital, Jaipur. And she's going to talk on orbital foreign body. So on to you, Dr. Maya.
Thank you so much, ma'am.
Yeah, let's
Thank
stick
you.
to 6 minutes.
Yeah, thank you for having me here. So I'm going to show you a few cases of orbital wooden foreign bodies, and basically it's a video presentation. So this young male who came to me with left eye exotropia, as you can see in the picture, and this was for last 1 year. And also he was having this adduction restriction and having a diplopia and a face turn to avoid that. You can see that the MRI is showing that the lateral rectus is thickened and there is some hypointensity inside, and he was being diagnosed as myocystis and myositis, and he was being treated with steroids. But I'm so sorry. So he was being treated with steroids for which he was not responding. And there were some atypical features, like you can see that there is some discharge coming from the lateral canthal area. And also on careful history taking, he said that there was a history of fall on a wooden stick. And I suspected there is a retained wooden foreign body, and that is causing this muscle thickening and fibrosis and restriction of the movements. So I explored the orbit, I disinserted the lateral rectus muscle, and to my confirmation, there were multiple pieces, as you can see, coming out from the muscle. And these were decomposed, disintegrated wooden pieces. And all the pieces were removed. I don't know, these black ones were the carbon particles. Then the muscle was reinserted and he regained his alignment, and the exo and the diplopia got cured. And he achieved this functional motility. So they may have chronic presentation and can be misdiagnosed because of the inconspicuous imaging features. Now, this young lady, she came to me after a corneal tear repair in the right eye. And again, she was having this ocular motility restriction. You can see that the eye is medially deviated And earlier she had undergone a granuloma excision from the conjunctiva. They were suspecting a mass lesion in the orbit. And it was referred to me because the movements were restricted. I ordered an MRI, and you can see that in the MRI, there is a large signal void foreign body, which is going into the ethmoid sinus. So again, there was a discharge over the caruncular area, you can see, and these were the sutures of previous biopsy site that they were suspecting a mass lesion over here. So I explored the medial orbit via this approach, and I could see the wooden piece that was lying there impacted into the medial wall. It was quite large to grasp. There was an open globe injury associated with that, so I have to be very careful and gentle. And this was a large piece of the wood that was there in the ethmoid sinus, around 4 centimeter in length. So again, this case tells us that if there is an open globe injury and movements are restricted, we should think that there might be a retained orbital foreign body, and conjunctival granuloma is a very common presentation in such scenario. Again, this lady, she was a 30-year-old female. She came to me with purulent discharge after like 2 months, since last 2 months, and she was being treated with dacryocystitis. And MRI showed that there was a linear foreign body, and we cannot see the entry wound. Sometimes these are hidden. So it has gone through the superior fornix over here, and we have to be careful while examining the fornices in such cases. Again, a young female, she presented to me with discharging sinus in the lower eyelid. Again, she was treated with as a case of dacryocystitis. In the orbit, there was nothing. And in the infratemporal fossa, there were multiple, you can see hyperdensities lying over there. And there was associated pus collection in the infratemporal fossa. So the foreign body has gone through the orbit and via the inferior orbital fissure into the infratemporal fossa, or it might have migrated over there. So as a protocol, we have to always approach through the entry wound. So I opened the wound through the inferior orbit. I approached. There was nothing in the orbit. The periosteum, you can say, is very thickened. And there was this granulation tissue, pus discharge coming from the infratemporal fossa. And I was not sure how to approach this area of the inferior infratemporal fossa. So I decided to go through the inferior orbital fissure, separated the periosteum, and then I started seeing some pieces of wood coming out through this fissure. So I blindly went with the forceps, and I began to take them out one by one. And multiple pieces, you can see, started coming out one after the other. But whenever I think that now it is the last piece, there was another big one which was lying next to that. So it was a blind procedure, and around 12 to 16 wooden large pieces were removed in this surgery. And I was sure that this must be the end of it. But with the wood, you are never sure. And this is the thing that we should always keep in mind. The patient came back after 10 days and there was a recurrence of pus discharge. Again, I ordered imaging, and there was a piece lying there in the infratemporal fossa, which was left. So this time I had to plan a bony opening, and I created a bony ostium over here, and I have to remove the foreign body completely under direct exposure. So this, after making this opening with the bone punch, there was a piece which was lying over there, which was missed in the first surgery. So that was then removed, and that was the last piece. And then the patient never came back to me with the pus discharge again. So the wound was closed and she recovered very well, you can see, and there was no recurrence. So to conclude, I'll say that orbital foreign bodies, particularly wood, they can have varied presentations. We should take a meticulous history. We should have a high index of clinical suspicion to establish the diagnosis so that we can intervene on time and can have a better prognosis. Thank you.
Thank you, Dr. Maya, for that wonderful presentation on orbital wooden foreign bodies. You have shown an entire range of foreign bodies. And as you rightly mentioned, we have to approach through the entry wound and we have to suspect more of it. So sometimes many of these foreign bodies can be associated with intense inflammatory reactions. I just have one question. What happens if it is locating within a very critical structure like an optic nerve, or how do you approach that? Or do you choose to leave any of these foreign bodies, not
I
a
think
wooden foreign body? Any other thing? Would you like to choose it to leave? What do you do?
Yeah, definitely. If it is not or it's not an organic or wooden foreign body, if you're talking about a metal that is inert substance. So if it is like not approachable, it is not causing any functional deficit, it is lying quietly in the posterior orbit, we can just follow up the patient. We can just leave them on observation, and we need not to touch them, because if we go to access that part, and we can cause more harm. So if it's not causing any movement limitation, it is not compressing the optic nerve and causing any vision deprivation, then we can just safely leave it. If it is accessible, it is in the anterior orbit, or it is impacted somewhere and causing some mechanical or pressure effect, then of course we have to remove it.
Thank you. Thank you. Wonderful talk, Dr. Maya. We go on to our last speaker, Dr. Tenarson, who's our vitreoretina consultant at the Eye Foundation Group of Hospitals. And he's going to talk on globe rupture, how to approach it. And it is 6 minutes only, Tenarson.
Yes, ma'am. Is my slides visible?
Yeah.
Okay. Yeah. So, good evening, everyone, and thank you, Dr. Chitra ma'am and Dr. Vidya ma'am, for this opportunity. So, I'll be showing some videos and talking about how to approach the cases of globe rupture. So, globe rupture is a common term used to describe all potential types of open globe injury. Vets have classified into open globe and closed globe. In open globe, we have laceration, rupture, and the zones has been clearly defined. So depending upon the prognosis is varied. So zone 1 includes cornea and limbus. Zone 2 is up to 5 millimeter beyond the limbus, and zone 3 beyond 5 millimeter of posterior to the limbus. So coming to this case, it's a 80-year-old female who had a history of fall and had injury to the left eye. And she got open globe injury to the left eye along with IOL expulsion. So she had a scleral tear at the site of tunnel, and the exploration has been done. You can see almost like 5 to 6 clock hours of perforation. The scleral tear has been sutured with the help of 70 Vicryl. The iris tissue which has been excised, abscission has been done. And in this patient, I have, and additionally, the globe was almost intact. So I tried to have, along with anatomical, I tried to give the visual outcome as well. So I have cleared all the hemorrhage, which is in the anterior segment, and pupilloplasty was done in addition to that. And scleral suture has been done. Once the globe is intact, I tried to do vitrectomy and clear the vitreous hemorrhage. And 3 ports has been made, and it was made sure that the cannula is inside the vitreous cavity. And usually in globe rupture, we have in a primary setting, we can do a proper globe suturing, and secondary setting, we can manage the secondary, the postvenous vitrectomy can be done for additional complications. But since this is an old age patient, to take up the patient secondarily for the surgery was very difficult, and the globe was intact and there was no leakage after suturing, I tried to go ahead with the vitrectomy in this case. And I have cleared all the vitreous hemorrhage, and retina was attached, and the hemorrhage which is anterior to the vitreous, everything was being cleared, and the patient has been left aphakic. All the ports entry has been closed. AC is formed, and then connectoral entry has been closed. So this patient did well. Postoperatively, this is ultrasound picture, and later on the patient had underwent secondary SFIL. So best corrected visual acuity, she had a 6/80. So this is another patient, so a young patient who had a history of trauma with a iron particle, who had while he was doing hammering, and he had a scleral perforation with a retained large intraocular iron foreign body. So this is an ultrasound picture as well. So in this patient, again, the management has been done at a single stage. So this is the entry scleral wound at infratemporal quadrant. So the entry wound has been left because I planned to remove the intraocular foreign body at the same site. So the ports entry has been made, and then vitreous above the foreign body, you can see the foreign body which is impacted below the inferior arcade into the choroidal and retinal layer with a localized retinal detachment. And the foreign body has been discharged from that impacted site. The bleeding has been stopped. So once this is done, the vitreous surrounding that layer has been cleared. So and the PFCL has been injected in the posterior pole to prevent that foreign body to damage to the posterior pole. Here I have been modifying the entry site where I have made 2 vital sutures and the 2 lips of the entry wound, so that while extracting the foreign body, we can retract the wound, so it will be easier for delivering the foreign body outside. So with the help of magnetic forceps, the foreign body has been tried to brought it out. But since the entry site and the size of the foreign body is also of same size, it was very difficult to, even with the retraction of the lips of the foreign wound, it was very difficult to get the foreign body out. So in the first attempt, it was not successful. So I tried to enlarge the entry wound so that it will be easier to deliver the foreign body outside. So again, with the second attempt, with the help of magnetic forceps, the foreign body is retrieved outside. So in this patient, the foreign body has been entered through the scleral entry wound. So since it is at the pars plana site, so I try to retrieve the foreign body at the same site through the entry wound. Hence, I didn't suture the wound initially because with the help of infusion, the globe pressure has been maintained. So it was easier to do that. So this was the metallic foreign body. So once the foreign body has been removed, the scleral entry wound has been sutured with the help of 6-0 Vicryl. And once with the proper position of the wound, the connective has been sutured. And later on, the vitreous has been cleared and vitrectomy has been completed. We have to make sure that the entire vitreous has been removed because you can see it's a large layer of impacted wound with underlying choroidal damage. So definitely there are chances of PVR formation. So the removal of entire vitreous is the key to the surgery. Sorry, I'll just go back. So with the help of tricot and the vitreous has been strained, the entire vitreous has been removed. And in this case, definitely there are chances of ERM formation is there. So hence definitely ILM peeling has been done to prevent future macular pucker and ERM formation. Because generally whenever there is a large break, the chances of PVR formation and ERM formation is very high, especially in young patients. So this step was done to make sure that there is no any scaffold for ERM formation in the future. So once this is done, fluid air exchange has been done and retina is well settled and endolaser has been applied to the large break and silicone oil has been injected and the ports entry were closed. So the patient did well. So this was a post-op slit lamp picture and patient had a best corrected visual acuity of 6/9 and is awaiting for silicone oil removal. This is the OCT picture. So coming to open globe injuries, to evaluation is very, very important. The thorough history, the nature of injury, and whether it's a workplace or occupation, whether it's an MLC or non-MLC, and it is what is the time lapse between the time of injury and presentation is very, very important. Baseline best corrected visual acuity, whether RAPD is there or not, has to be definitely noted. Extent and the location of wound has to be noted. Generally, when you examine the patient in slit lamp or torchlight, globe rupture usually have a thick subconjunctival hemorrhage with a scleral step sign and with the underlying any bulge because of the expelled lens, and you will definitely have a peaked pupil towards the scleral wound. Sometimes you will have occult globe injury where you have a deep anterior chamber with a posteriorly retracted plateau iris, and definitely patient will have a hypertonous globe with associated extensive hemorrhagic choroidals. And if the patient has a multiple injuries, definitely imaging is needed. CT scan is definitely done to rule out any associated orbital wall injuries or retained intraocular foreign body. If the patient had an RTA cases, definitely assessment of airway, breathing and circulation is important. That is the primary treatment, followed by ocular injury. Globe rupture has to be managed. So etiology, if you come to, usually in children, it happens because of the sharp objects. In adults, it happens in workplace injuries, whereas in elderly, it is most happens because of the fall. So if you look at the intact globe those who doesn't have any prior intraocular procedures, usually the rupture will be behind the extraocular muscle insertion where the sclera is thinnest. Whereas those who underwent prior intraocular surgery usually it occurs at the giveaway at the site of prior incision site. So management, definitely most of the cases because of globe rupture, it has to be taken under general anesthesia because of two things of the general condition and pain while doing a local anesthesia, and because you cannot do give a local block because it again induces the expulsion of already pre-existing large rupture. So local anesthesia is preferred only in cases of minute perforation or very bad globe is well preserved. Definitely injection TT prophylaxis has to be given along with systemic antibiotics. So under anesthesia, globe exploration has to be properly done. Thorough peritomy has to be done wherever the suspected area of globe rupture, and hooking of recti muscle has to be definitely done and retracted to see the posterior extension of the rupture, and scleral repair has to be done with the help of 70 or 60 of IT depending upon the integrity. And definitely there is an expulsion or of vitreous or any choroidal tissue, it has to be cut and removed. And during this procedure, definitely you will have a hypotonus. So we can form the globe with the help of injecting viscoelastic solid, or we can use anterior chamber maintainer for some time so that globe integrity is maintained, and then we can suture it properly. If there is an associated corneal perforation, it has to be formed as well. In case, if possible, we can do a pupilloplasty and AC clot removal can be done. If the patient had anterior capsule rupture or lens extraction or IOL expulsion, we can remove that as well. Generally, in cases of globe rupture, primary setting, we have to integrity has to be maintained. So always suture the wound. So we can always delay the possible vitrectomy for the secondary setting, and we can take up the patient for the second stage. But in very few cases, if you feel the globe integrity is very well maintained and the patient can go ahead with the vitrectomy, you can decide. In such cases like dense vitreous hemorrhage. So definitely, if there is a retained intraocular foreign body, it has to be removed at the same stage. And if you suspect if there is a delay in the treatment, and if there is a long duration in the time of presentation, and if you suspect endophthalmitis, you can always give prophylactic intraocular antibiotics. These are all the very poor prognostic factors. If the patient presenting visual acuity is very less, and if the posterior globe is involved, if RAPD is there, if the longer wound length is there, and if associated endophthalmitis and retained intraocular foreign body, if associated retinal detachment, all these patients has poor prognosis. And definitely documentation is very, very important, and patient has to be explained in very detail about the management, because most often these patients will have very poor visual acuity, and most often they might go for phthisis bulbi. So the proper consent before the procedure is very, very important, because most often these cases will have a medico-legal cases. Thank you.
That was a wonderful talk, Tennyson, very well covered. And Vidya, anything before we conclude? I think
Tennyson has said it all, so I don't have any questions to ask. It was very crisp presentation.
Dr. Sonam, Dr. Hedge, anybody, Roshmi, any final comment, question? I think we had a wonderful set of talks today, just amazing talks.
Everything was covered. Thank you so much for this opportunity. It was really great. Thank you.
Yeah. So I think each of these talks have been so good, so well discussed, and I do hope you all spread the content of the topics among your friends and juniors so that they find it as gainful as all of us did. Thanks a lot, each and every one of you, for being a part of this wonderful webinar, and thanks Vidya for coining together the best topics possible. Thank you so much.
Thank you. Thank you, ma'am.
Thank you. Bye-bye.
Bye.
Thank you, everyone. Bye.
Bye. Thank you, everyone.
Thank you. Thank you.
Thank you.
Bye.